not manic, but it's really happy. It's really happy.
Oh, good. Yeah, I'm glad you're happy. I think I'm tired after that weekend.
Mm-hmm.
Couples therapy was a big thing.
Hello, everyone. How's it going? Can folks hear me? Awesome. So, a couple of things. First, you probably all saw the email as well as the announcement from the school that we will be resuming in person next week. And so I said in my email that if anyone is not comfortable with that, just let me know. I'm happy. I will continue to be Zooming and recording and so on and so forth for folks who aren't comfortable with in person for whatever reason. That being said, I'm cool with it, but if you have other classes that are also returning and you feel like you would be more comfortable doing so, I would encourage you to go through the DSO too. That way, if anything does come up, you have that added protection. But for the sake of this class, I don't need an explanation. So we're going to do things a little bit different today. We're going to start with sleep-wake disorders, and then we're going to be talking about sexual dysfunction, paraphilias, and gender dysphoria. So for that particular portion, I'm going to be using the lecture notes that the textbook provides. And for that, I want everybody to have their DSM available, and we can kind of discuss the differences and the actual DSM criteria compared to what your book talks about and some of the sort of problematic things that come up there, and kind of do like a compare and contrast. So I'm also drinking my coffee out of a straw. Don't ask me why, but it felt like a good idea today.
I was curious. Somebody in the class said that Quizlet was a great way to study, but how do you find your class? Like, how do you find what you should be doing? Somebody suggested it, I think.
So Quizlet is one of many websites available. You can search by textbook, and really all it does is takes the questions from the textbook that you should already have and compiles them into one piece. And it can also be problematic at times. Like, let me take a look here at our textbook. I don't actually see our book on here. David Barlow. Okay. Yeah, so it'll basically just takes the questions from the textbook already and adds them in there. The other thing is that a lot of these are user submitted, and so there's no guarantee that the answers that you're getting will be correct. So, I mean, it works for some things. It's great for things like math or things that have more objective, correct or incorrect type answers. But for essay questions and that kind of thing, which we don't have in this course, your midterm will be all multiple choice. There's not a lot actually on there. So, I mean, check out the free version, see if there's anything good, but don't pay for it. You'll be wasting your money.
Thanks.
Can I ask really quickly if the midterm is on chapters 1 through 10 and then additionally 14, or the halfway point 1 through 8?
Let me pull up your syllabus here. It will be everything.
So the 1 through 10 and then also 14.
Mm-hmm.
Okay.
Yep.
Thank you.
So everything covered in the first couple weeks here, plus chapter 14. Assuming we get to all of it. I think we will. today's we will be able to make it through pretty much everything. And then next week is just one topic. So if we do need to go over a little bit, we can. So sleep-wake disorders, how far did we get last week? Did we start them at all? Oh, go ahead.
Sorry, I have one more question about so when you say like they take the questions from the book, are you talking about the concept checks? Okay, so for studying, you actually feel like maybe, are you suggesting that would be a better place to spend time is really with those?
Yeah, I mean, just with the book, yeah, like don't pay for something that you already have access to. The other thing is that sometimes Quizlet and similar websites will take questions from test banks. And so we discourage that for a multitude of reasons that I will not get into, but I'm sure you can use your imagination. So with sleep-wake disorders, how far did we get? Did we start, or did we get about, because the 2 sections of the course are in different places, and I don't remember. I believe we started and made it through hypersomnolence, but I could be having all of you confused with my Tuesday night folks.
I don't remember starting the sleep.
Okay, I didn't think so.
I don't either. Yeah.
Okay. Yeah, I didn't think so. I just wanted to make sure. All right, so we will go through these. It will probably not take a full hour, and then we will move on to the second portion of class after a break. So 2 different types here. Dysomnias and parasomnias. So dysomnias are issues with how much the person is actually sleeping, and then parasomnias are all about the things happening during sleep that are not considered normal or don't fit within normal limits of what's supposed to happen during sleep. So this could be things like behavioral issues, physiological issues like restless leg syndrome, things like nightmares, all that kind of stuff. Whereas dysomnias are going to be things like sleeping too much, sleeping too little, having low quality sleep, so on and so forth. A lot of the diagnoses in here, pretty much all of them, require the use of different neurological testing. And there are different criteria between the DSM-5, the ICD-10, and an additional manual called the International Classification of Sleep Disorders, which is in its 2nd edition. So your book kind of incorporates all 3. We'll be focusing on the DSM criteria today, since that's what most of you will be using in your internships, not your jobs. But just be aware that, you know, other criteria do exist. You will find that the coding, as always, tends to use the ICD-10. And if your client is going to a sleep specialist or a neurologist, they will be using some combination of the 3. Why are there neurological disorders in the DSM-5 in the first place? If it's not really all the time within our scope to diagnose, and we should be working with other specialists. So for instance, things like cataplexy, it could be related to various things. Maybe it is just psychogenic, in which case it's fully within your scope to diagnose, especially after you know, everything else has been rolled out. The other piece here is that treatment is often behavioral psychological. So maybe the person has really bad insomnia or hypersomnolence, and they start on medications, they work with various specialists, but it's not getting better. A lot of times there's also treatment around things like sleep hygiene. It could also be an underlying issue with a behavioral problem. So let's say you've got kiddos that come in and are having all sorts of issues at school. Maybe they're having trouble focusing. Maybe they're having trouble, you know, with things that might look like ADHD or things that might look like an oppositional defiant disorder, but it turns out there's an underlying sleep problem. And so you really want to be fully aware of these various issues so that you can rule those things out, you know, and make sure that they're getting seen by the specialist that they need. We want to be able to differentiate from other issues. So if a person has PTSD, they're having nightmares as a result of that, as opposed to just nightmare disorder, where it could be related to trauma, but they don't meet full criteria for PTSD, all that sort of thing. And then last but not least, almost everybody that has a sleep disorder tends to develop other issues like a related depression or anxiety or issues of focus and concentration, and all of these sort of residual problems that happens when someone struggles with their sleep. With certain sleep disorders, we'll talk about there could be behavioral disturbances that cause relationship issues. And so if you're doing any kind of marital counseling, other types of counseling with the person to kind of just help them cope with whatever those behaviors are. So even though we're not going to be the ones doing things like an EEG or a PSG, these actual neurological testing, we will still be providing treatment, and we will still, you might be that kind of frontline person that refers them to those testing. So first one here, I'm going to shut this door real quick because there's noise. The first thing here is insomnia disorder. Everybody's heard of insomnia before. So basically here the person either isn't sleeping, and when they do sleep, or when they do sleep, they have the sleep feels non-restorative. So this could be a couple of things. It could be that they never fall asleep. It could be that when they fall asleep, they wake up a lot. It could be that they wake up way too early and they can't fall back asleep. So one of those three, or all of those three, or some combination. Something to look for in kiddos is that they can fall asleep or stay asleep, but that it requires ongoing intervention from the caregiver. And we're not just talking about, a newborn infant where they have to wake up every 2 to 3 hours to eat or breastfeed. We're talking about sort of beyond that regular developmental phase where the child or infant is not sleeping in addition to that. It's also something where we want to roll out additional medical issues, right? So if your baby is colicky, let's get them seen and make sure that they don't actually have acid reflux, things like that are waking them up. So with insomnia, this is happening frequently and it's persistent. So at least 3 nights a week for at least 3 months. Again, our magical 3s that the DSM loves. The person has plenty of time for sleep. So the insomnia isn't due to their work schedule. That's a separate diagnosis that we'll talk about later. It's not due to things like having a really, really, really bad mattress, or being uncomfortable, or having physical pain in some way, although you might co-diagnose, right? You might have a comorbidity with something like physical pain or some sort of other issue like that, but this is in addition to whatever's happening there. It's not due to something like being bipolar and having a manic episode. Should be criterion F. It's not due to something like an additional sleep-wake disorder. So they're not only having it while they're having other symptoms like nightmares or other related things that we'll talk about. And it's not due to medication or a substance. There are medications that people take that can keep them awake. So you'd want to rule out those sorts of issues, and you would do that by seeing if this was a problem before the medication, if it's a problem after the medication, so on and so forth. When we get to the end of this section, there is also, as usual, a medication or substance-induced sleep disorder, so we'll talk about that. A couple things with insomnia. So let's say it is related. It's not necessarily caused by, but it's related to something like another mental disorder. Let's say that the person has major depressive disorder, or they're having a depressive episode and they're having a sleep disturbance because of that. If the insomnia is really predominating the clinical picture, then you would add this as an additional diagnosis. Let's say the person has PTSD and they're not able to sleep because of the nightmares, or just that hyperarousal, hypervigilance that's happening, that sympathetic nervous activation is happening. And again, the insomnia is sort of a main feature, one of their sort of chief presenting problem or chief complaints. Then we would add, the additional diagnosis. Same thing if it's related to issues like pain or other medical problems. You can add all of these specifications. Additional specifications are things like if it's episodic, if it's persistent, or if it's recurrent. This is fun because we just set up here that it has to last for at least 3 months. So what often happens is you have somebody that comes into treatment and maybe it's only been happening a few weeks, or it's been happening 2 months, and then we're going to say, okay, well, we're having an episode right now. Let's wait and see. If it goes longer than 3 months, then we're going to start calling it persistent. So this would be used diagnostically if the person hasn't been having symptoms that long. And we'll talk about kind of the difference between that and, say, an other specified insomnia disorder where maybe the person had the symptoms for a month or 2 months and then it stopped before they reached the 3 months. So the episodic would be more used to something like, let's say they have these frequent episodes, but they never last more than a month or 2 at a time. Recurrent, you could use that too. What's that?
Is the episodic the way that you judge if it's recurrent? So like episodic would mean that they've had their symptoms for at least 1 month, but less than 3. and then they had 2 of those episodes within 1 year, is that what would count as recurrent? Or is it just like, it was 2 weeks here, it was 3 weeks there, it was like...
Yeah, absolutely. And it's really up to your clinical judgment, because we know that even though the research says the average is 3 months, you know, human beings don't exist within those sort of neat little categories. So it's not like you reach 3 months and bam, you're better, and then you have another episode. So you would say recurrent if the person is having multiple episodes. You could say episodic, comma, recurrent if you really wanted to get specific. It really just depends on how that person's presenting and what their complaint is. You know, no one's going to audit you and say, hey, this was only a month each, but they had multiple episodes of 1 month. That being said, if you wanted to get really pedantic, you could then say that that's an other specified insomnia disorder, but you don't have to. You could call it recurrent. I tend to use episodic if it's the first person's episode, only because that's kind of a way of saying we don't know yet, we're going to see what happens, but it really just depends. It could also be episodic as a result of, like, let's say the person had some kind of surgery or some kind of medical issue, and then they had an insomnia episode. It could be an episode due to a major stressor in their life, things like that. So associated features, again, the person might have pain or physical discomfort that's keeping them awake. They could also have pain or physical discomfort as a result of the insomnia. We know that when people don't get sleep and they don't get restorative sleep, they tend to start to experience issues like chronic pain, fatigue, obviously, all of those kind of chronic illness type things. There are some physiological cues as to what's actually going on. So it could be due to the body temperature not dropping unless it's the way that it's supposed to. Typically when it's sleepy time, your body temperature drops a little bit, your heart rate goes down, your breathing goes down. This is all due to your circadian rhythm, melatonin production, and that kind of stuff. So if the body's not doing what it's supposed to do, maybe it's a melatonin issue and taking melatonin will fix it. Maybe it's a blue light issue. We know that blue light is one of the things associated with melatonin production. So like blue light glasses, for instance, completely useless for eye strain, does nothing for eye strain, despite the sales pitches you may have heard. However, they are very, very, very useful for limiting or for allowing the body to produce melatonin in its natural state, because our body produces melatonin based on sunlight and the blue light emitted from the sun. And so if somebody's having struggles with sleeping, then we'll talk about, like, let's get a blue light blocker, or let's not use screens after a certain time, those kind of things. Stress and anxiety. So again, let's say the person has some kind of anxiety disorder, or maybe they don't meet full criteria for anxiety, but this could be something like they've had a job change. They have something really exciting going on in life. It doesn't have to be a negative thing, right? It could just be some sort of sympathetic nervous system arousal due to life changes or just things happening. Maybe they're getting married, maybe, you know, all kinds of stuff. We do want to differentiate this from issues with newborns. So if the person isn't sleeping because they have to wake up and feed or change a baby every few hours, that's not the same thing as insomnia unless it continues after. So let's say their body is then sort of retrained itself and they no longer have to get up, but they find themselves waking up automatically as a result of that change. And then again, in children, it doesn't just have to be that they can't sleep. It could be that they can't sleep without being rocked, or they can't sleep without having some sort of caregiver present. And again, when it's developmentally inappropriate. So infants, totally normal. Toddlers, sometimes normal. This is when it becomes all the time. Talk about cycles. So let's say the person has some sort of pre-existing issue with sleep disturbance. And then there's going to be back and forth between trouble with how they take care of themselves. So maybe they have poor sleep hygiene. Maybe they have trouble sleeping, so they get up and they play on their phone, which then emits blue light, which then gives them more trouble sleeping. Maybe there are cultural demands like having a night shift or swing shift or having a new baby, all those kinds of things. Then the person starts taking naps. They might start self-medicating. Let's say they start taking Benadryl or another anticholinergic every night, which helps them fall asleep, but then wakes them up later, because as soon as that medication wears off, their heart rate spikes a little and then they wake up. Could be all sorts of things, but these cycles tend to become very circular and they repeat themselves. So often our job as therapists will be to help the person with these issues around sleep hygiene. And in some cases, daytime naps actually are useful. We'll talk about that a little bit with some of the other neurological disorders, like narcolepsy. So we want to help the person come up with a routine that works for them. Even though we might not be the one diagnosing something like narcolepsy, we are going to be the one who's helping them cope with it and kind of come up with a good routine.
So if you had somebody whose sleep was disrupted for a religious reason, maybe they're praying throughout their day, you know, and what would you, and then they can't get back to sleep, or they keep waking up, you know, whatever is happening for them, how would you, I mean, it's not really, if you've been sleeping, it's not really a sleep hygiene thing. It's like, is that just something they're going to have to deal with, or how do you address that?
Well, it depends. I mean, if they're, you know, engaged in some kind of faith practice, or maybe they're supposed to stay up all night and engage in prayer, fasting, that kind of thing. But then let's say it keeps happening after that period is over and they are no longer in control of it. So there's a difference, like I'm choosing to do this versus I'm not choosing to do it, and it just keeps happening outside of my control. And that would be the main difference. So let's say somebody does that and they have like a 24-hour period where they stay awake in prayer or fasting or some other kind of faith-based behavior, but then for the next 6 months, they find themselves being unable to sleep. That's when I would look at something like an insomnia diagnosis, or potentially even a manic or hypomanic, particularly if it is sort of outside the normal limits of whatever their faith practice is, if that makes sense.
Yeah. So what about the people who are expected to pray their entire life, right? Like this is not an episode. I don't remember if it's Muslim or I'm having a moment, but so what do you like, what if it's not going to end?
I'm not sure quite what you mean. I don't know of any.
Like there's prayers, there's people I think who have to pray every 4 hours, 6 hours. I don't know. I don't know enough about it to say anything, but there are some religions that require continuous prayer like throughout the day. If anybody knows about it, you can help me. But
like with Islam, for instance, there are several prayer times during the day where people will stop whatever they're doing, orient themselves physically toward Mecca, and then they will engage in prayer for a few minutes, but typically they're not required to do so at night as well. There might be more extreme type lifestyles where maybe somebody's a monk or a nun and that sort of thing, and it's kind of the same thing where they're not required to do so during sleep times. And they also, in those kinds of settings, people will typically arrange their lives around that. But it's pretty rare. There might be certain periods. So during Ramadan, for instance, people will fast, but then they have a break fast at certain times of day. Or during certain Jewish holidays, a person might stay awake for a whole time and engage in prayer or meditation of some kind. But it's always followed by a period of, okay, well, now you're allowed to sleep, or now you're allowed to eat. And so most of these traditions have developed, you know, compensatory behaviors over time, where maybe the person stays awake all night praying, but then they spend the next day or two sleeping to kind of make up for it. So the insomnia would be diagnosed if they continue to have this trouble, even when they're not trying to, and when it's out of their control, if they're not purposely keeping themselves awake for some reason.
Okay. Yeah. I thought they had to pray at night too. So that helps.
Nope. So differential diagnosis, so normal sleep variations. Some people sleep in on the weekend, they stay up later, whatever. Situational or acute. So situational would be something like new baby, staying up all night because I have to take care of it. Or, you know, there's a protest going outside of my house and I want to make sure nobody breaks my windows, or, you know, whatever the issue is. Or I'm having an all-nighter because I have a paper due, or I'm going to stay up all night and have a Hobbit marathon, whatever floats your boat. Again, what it comes down to is control versus not control. And with situational, it could be due to something like stress. So you got a big day tomorrow, you're getting married, you're presenting, you're graduating, whatever. You can't sleep because you're stressed. Not the same thing. So if it's only for a day or two, it doesn't last doesn't last multiple days, multiple months, so on and so forth. Delayed sleep phase and shift work type. Other circadian rhythm sleep-wake disorders, we will talk about those. Restless leg syndrome, we will talk about. Apnea, we will talk about. Narcolepsy, we will talk about. And parasomnia, we will talk about. So basically, if it's not another sleep disorder and they're just not sleeping, and we're not entirely sure why, again, unless it's pain, discomfort, that kind of thing, that's when it's insomnia. On the other hand, hypersomnolence. I'll also be calling this hypersomnia, so we'll kind of use those words interchangeably. So this is excessive sleepiness, and maybe the person is sleeping a ton. So at least 9 to 10 hours a night. They say despite a main sleep period lasting at least 7 hours, which is the average, you're supposed to get 6 to 8 every night. In addition to sleeping too much at night, the person is also having recurrent naps, sometimes unconsciously, like they fall asleep while they're driving, they fall asleep during a movie all the time. And it's not just because they're tired because they didn't get enough sleep. So in addition to sleeping, in addition to having a normal amount or too much sleep at night, they're also falling asleep during the day. If they are sleeping, at least 9 hours a night and it's not restorative, they still feel tired. And if they have difficulty being fully awake. So typically somebody with hypersomnolence, when you attempt to arouse them, they're going to be a little disoriented, a little fuzzy at first. And they might have a period of time where that sleep-wake transition takes a little bit longer than most people. So this is in a lot of ways the opposite of insomnia, except for the, kind of ongoing daytime fatigue. So again, it's happening frequently, persistently, 3 by 3. They could have some additional impairment. So this person is having trouble remembering, they're having trouble focusing, all of that executive functioning stuff. It could also be impairment just in their life. So I can't go out because I'm tired and I want to sleep. I need to sleep, 10, 11 hours every night. Or I can't go out because I'm going to fall asleep while driving. That sort of stuff. And it's not just because your professor is boring and you're falling asleep because you stayed up all night studying and you are tired of the drone of my voice. So this is outside. It's not just situational. It's happening kind of all the time. It's not a result of another sleep disorder. It's not due to substance or medication. It is not due to, or it could be due to, but it doesn't, it sort of predominates the picture with something like major depressive disorder where the person is sleeping a lot. So this would be, that can be a symptom of major depressive disorder, but this would become kind of the main presenting symptom, and in which case we would diagnose it in addition to the major depressive episode. Same thing with other issues like anxiety, schizophrenia, chronic pain, autoimmune disorders. It can be a symptom of those things. And in addition to that diagnosis, this sort of seems to be kind of one of the chief complaints that the person is coming to you with. So a couple, did we talk about it yet? Not yet. Okay. So specifications. If it's with an additional mental disorder like major depressive disorder or substance use thing, like maybe the person's doing heroin, so they sleep all the time. Okay, let's add that. Other medical conditions, another sleep disorder. So maybe in addition to hypersomnolence, they could also have a nightmare disorder. And so we would diagnose both. Specifications for how long it's been happening, and then specifications for mild, moderate, or severe. Note that unlike insomnia, we actually give specifications here for the severity based on how many days a week it's happening. With the understanding that, again, humans don't fall into neat patterns. So there might be a week where it's only 1 to 2 days a week. There might be a week where it's 5 to 7. You really just want to look at averages and have the person keep some kind of sleep diary or some sort of journal to track how often it's happening, and then go with the average. You don't need to change your specification every week that you see the person, because that's kind of a pain and the whole thing.
So I think next to moderate, you need to say 2 to 4 or 3 to 4 days a week. You asked to be told, so otherwise.
Absolutely. Thank you. So a couple things that happen. The person's sleeping all the time, but they still don't feel rested. They still don't feel rested. They still feel tired. They fall asleep pretty easily, unlike with insomnia, but they might have trouble with waking up. When they wake up, they might be combative, disoriented. They might have some sleep inertia. They might have some sleep paralysis where they can't move at first. They might have some issues with breathing when they first wake up. So again, there can also be issues with those sleep-wake transitions. So often, and remember this is only one of the potential sub-criteria for criterion A, but often it does end up being longer than 9 hours a night. The napping can be voluntary, involuntary, but often it is involuntary. So the person just falls asleep without meaning to. Maybe they're sitting in a chair or they're, doing something else, but they're not actually going to bed for the purpose of napping. Tends to be progressive, so meaning it does get worse over time. Typically starts young adulthood. Fairly high prevalence. So about 1% of the population, and then of course, higher prevalence in sleep clinics, because if people come to sleep clinics, it's because they have a sleep issue. There could be, medical problems. So if we see this frequently with folks that have some kind of virus, and the virus has gone away. So this could be things like meningitis, mumps, measles, rubella. We're seeing it a lot with COVID folks. It's one of the main symptoms of long haul COVID. Not a lot of research on that yet for obvious reasons, but we're seeing it pretty frequently. There's links to head injuries. Doesn't always have to be, but that can be sort of the underlying cause. There does appear to be a genetic link. So it could be due to just having, so let's say you have twins who develop some kind of virus. They have one twin develops a hypersomnolence, the other is more likely to, but there also appears to be specific genetic links, specific genes that account for people who just maybe need more sleep in general. And then it sort of spirals from there. So when you do actual testing for this person, and this is how we would differentiate it from other sleep-wake disorders, it looks like for the most part, their sleep phases are undisturbed. They're not having any behavioral issues. They're not having any changes in their REM or other sleep phases. There sometimes is increased slow wave sleep phase, but not all the time. So again, you want to differentiate this from just the person's really tired or they're getting over being sick. Poor sleep quality in general because they have a bad mattress or they're in some kind of pain, so they're fatigued because of that. It can be linked to those things, especially chronic pain. But again, it would be kind of its own additional main diagnosis. Breathing related disorders. So the person has apnea, so they end up having to sleep longer. Circadian rhythm disorders. The person's awake at night because of work, so they have to sleep longer during the day. Parasomnias, which we will talk about, and of course, other mental disorders. So if it's just a symptom of major depressive disorder, I probably wouldn't give them the additional diagnosis. But if they are experiencing it to a point where it sort of outweighs the other symptoms, then I would say, major depressive disorder and, hypersomnolence disorder. Narcolepsy. So narcolepsy has lots and lots of stuff in the DSM around levels and labs and what the actual PSG looks like. Again, those are not things that we can diagnose, obviously. Your therapist should not be drawing blood and testing it for stuff. If they do, you should find a new one, maybe report them to the board. But people will come to you because they are having trouble coping with it, because it's a really just tough illness to deal with. And people could come to you because they think it's something else. Maybe they think it's PTSD, or maybe, they have all these other sorts of issues, especially in children. It might look like a behavioral issue, and then it turns out it's this neurological thing instead. So here, the person has an irresistible need to sleep, meaning they have to sleep and there's not much they can do about it. So it's involuntary. It's happening at least 3 times a day for at least 3 months. So again, our 3 by 3. And they have to have at least one of these. So again, might look like what we think is a seizure, but we're going to differentiate from that later. So they're experiencing cataplexy, which is basically everything goes limp. So it could either be these sort of brief periods, and they have really positive emotions. So they could be laughing or joking, and then all of a sudden they go limp. It could also be when they first develop it, because the cataplexy tends to happen early on. It could be that the person, especially with children, you have these neurological, what appear to be tics, where they are grimacing a lot, the jaw's opening, the tongue is moving around in ways that are abnormal, and they might not have an emotional trigger. So you want to look for both. It can be one or the other, or it can be both. We're going to watch a video that may or may not work. Nope. Okay.
Narcolepsy is a chronic condition that causes excessive daytime sleepiness and leads to an increased tendency to fall asleep during daytime activities. The majority of people who suffer from narcolepsy also experience cataplexy, which involves brief, sudden episodes of muscle weakness or paralysis, often brought on by strong positive emotions. The muscle weakness in cataplexy may be severe enough to cause someone to fall to the ground and be unable to speak or move for a short period of time, despite remaining conscious. Patients with narcolepsy also often experience other sleep-related problems, such as disrupted sleep, sleep paralysis, and hallucinations when falling asleep or waking up. Today, narcolepsy is often classified as narcolepsy type 1 or narcolepsy type 2. Type 1 typically involves narcolepsy with cataplexy and low levels of a neuropeptide called orexin, also known as hypocretin. Type 2 does not involve cataplexy, and levels of orexin are normal. Narcolepsy type 2 generally has less severe symptoms, but little is known about its cause. Narcolepsy type 1 is linked to a loss of orexin-producing neurons in the hypothalamus, leading to low orexin levels. Orexin neurons have an excitatory effect on several regions of the brain that are involved in promoting wakefulness and suppressing REM sleep. Thus, the loss of these neurons leads to deficiencies in maintaining wakefulness and is linked to the dysregulation of REM sleep. This REM sleep dysregulation is thought to cause episodes of muscle paralysis and other aspects of REM sleep to occur during wakefulness, which is the basis for cataplexy. The cause of the loss of orexin neurons in narcolepsy is not completely understood, but several lines of evidence implicate an autoimmune mechanism. According to this view, a combination of genetic and environmental factors leads to an inflammatory process in the brain that causes the immune-mediated destruction of orexin neurons, bringing about the symptoms of narcolepsy.
So, in the DSM, they do talk specifically about the various
Welcome
hypocretin.
to 2-Minute Neuroscience, where I simplistically
the levels of hypocretin and the other neuropeptides that are involved. Once again, you would not be diagnosing that, but based on their lab tests and all that kind of thing, you would see these. The type 1 and type 2 are not in the DSM. Those are in the International Classification of Sleep Disorders, second edition, so ICSD 2 as opposed to ICD-10. And again, most sleep specialists will use that, but both of the, all of these different classification systems exist. So you don't necessarily have to worry about type 1 and type 2, just be aware that they exist and kind of know that there is a difference. So with one, you see these deficiencies in the neuropeptides. With the others, we don't necessarily. We also know that this isn't due to some kind of other injury. So the person doesn't have encephalitis. The person isn't currently experiencing measles, or another related swelling, any of that sort of stuff. Another thing that happens is that when the person does a sleep study, you'll find that their REM is going to be less than, it doesn't last as long and it occurs less frequently than it's supposed to, which is also, sort of lends credence to this idea that these neuropeptides that arouse the brain are not working the way they're supposed to. Specifications. So the specifications in the DSM, instead of just doing type 1, type 2, which would be with or without the hypocretin deficiency, you have all these other options, or with or without the cataplexy, you would have all these other options here. So if they do not have cataplexy, but they do have hypocretin deficiency, if they have cataplexy, but they do not have hypocretin deficiency, again, you would probably not be the person to diagnose this, but they are aware, so they are there, and so you should be aware of them. Secondary to another medical condition. So that could be something like they do have some sort of brain swelling or they have had some sort of infection. There is such a thing as narcolepsy that is etiologically related to type 2 diabetes and obesity. And it's due to this genetic issue where essentially the body isn't producing hypocretin the way that it's supposed to, but it's a result of issues in the limbic system and in the digestive system that's related to type 2 diabetes.
Question on that: if they have cataplexy, but we don't know the hypocretin deficiency levels, like what do we put in that case? Do we add a specifier or we don't?
Nope, you would not add a specifier, and you would refer them for lab testing and for a sleep study, because we don't know, right? We want to, let's say that they go and get lab testing and we're not totally sure what it is, because you're also going to want to, you're going to want to look at differential diagnoses like dissociative episodes, all that sort of stuff. So you would wait and add the specification until they actually do the lab work in the sleep study. So things that happen for folks with narcolepsy, like they said in the video, they might have hallucinations or what appear to be hallucinations. So this isn't it, but we also want to make sure it's not due to something like schizophrenia. They might have some lucid dreaming, which again is related to that REM sleep disturbance. They might have sleep paralysis, which is related to the cataplexy. Pretty rare in the general population. And there are two sort of major peaks of onset. So it tends to happen in early adulthood or in middle adulthood. Not a lot of research as to why. It's just statistically what's happening. A lot of it could just be because that's when people happen to go to the doctor and have that complaint. The onset can be abrupt or progressive. And if it is abrupt, if it just starts happening all of a sudden, it tends to have more serious symptoms and it tends to be associated with another medical issue.
I have a question about cataplexy, how you just said it's often like associated with positive emotional experiences. Is it not associated with negative experiences?
With narcolepsy, not so much. And that's kind of one of the big sort of distinguishing features is with something like a drop seizure or a sudden loss of movement like atonia or akinetic, it's usually in response to stress, typically a negative emotional experience. But with narcolepsy, it tends to be the person appears really, really happy, especially in children. They'll be laughing and then they fall asleep. So that is one of the main, yeah, it's interesting. There's not a lot of research as to why that happens. Etiologically, it's not totally understood, but that is one of the main distinguishing features. Mm-hmm. The other thing that distinguishes it from something like epilepsy is so people with epilepsy can have these episodes in response to any kind of strong emotion. But with cataplexy, it's the muscles completely loosen as opposed to tensing up. So if the person's having like the pterodactyl hands like this, where they're really tensing all of a sudden, or they go rigid, that's not cataplexy. Cataplexy is the opposite, where the person goes completely limp.
I just think it's fascinating because on case study 14, they say that Betty has cataplexy, but it's in relation to a fight with her roommate and then a car accident. So could that mean that it's not cataplexy, but they're saying it is?
Well, it could be that it's cataplexy due to something else. So we're going to look at lots of rollouts.
Okay, I'll wait for that.
Mm-hmm. And again, it says that it's often due to positive emotions, but it doesn't have to be all the time. So apneas. Most people have heard of apnea. There are two different kinds. There's obstructive and there is central. So with obstructive, it's exactly what it sounds like. It's due to something happening in the breathing system that is physically obstructing the ability to breathe. So person's going to have to do a sleep study, which is PCG, polysomnography. In order to meet the criteria for this diagnosis, it has to show at least 5 episodes per hour of sleep. So it's happening frequently. They might have some other breathing disturbances. If you've ever heard somebody with apnea, it might sound a lot like they are gasping. They might stop breathing completely for a few seconds. They might snore pretty loudly. And they don't feel good about their sleep. So they wake up, they're still tired, they're fatigued, they're not having restorative sleep. Could also be, so let's say they don't have A or B, but they're having at least 15 obstructive episodes where something's blocking the breathing during each hour of sleep. And again, this would be based on average. So if they have 1 hour of sleep where they have 16 and the next hour of sleep where they only have 10 and, and so on and so forth, you're looking for an average of 15. You're not looking for what their sleep specialist is. Fairly high prevalence here, 1 to 2% in children, 2 to 15 in middle-aged adults, 20% or more in older adults. So prevalence being cross-sectional point in time, it could be that it gets worse over time. It could also be that it is more likely to happen, have later onsets. So the later onset has a little bit to do with BMI, but it also has a little bit to do just with weakening of the muscles as people age. It can be due to something like tonsillitis, especially in children. It can happen with women following menopause and just older adults in general, which has more to do with age than it does with menopause itself. Lots of issues here. So people that have obstructive sleep apnea tend to have a lot of trouble during the day because they're fatigued, which is true with all sleep disorders. This one just has a lot of research on it because it's so common and because it's one of the things that people go to, participate in studies for more frequently because of how common it is and because of how often people seek out treatment. Central sleep apnea, on the other hand, is not necessarily due to some sort of actual physical obstruction. So a couple different types. Could be idiopathic, which means that the causes aren't really known, which is fairly rare. It could be due to Cheyne-Stokes type breathing. So this happens with folks that have a history of different types of medical issues. So it could be a result of strokes, heart failure, renal failure. If you've ever worked in dialysis, you see this a lot with dialysis patients because of the renal failure. So this particular breathing pattern is they have these crescendos and then these decrescendos where they start breathing really, really intensely and then it goes down. And so you kind of have this pattern where instead of having even breaths, inhales and exhales, they increase in intensity and then decrease in intensity. And it could be due to opioid use. So this could be maybe somebody's on a pain medication or maybe they're using some kind of illicit substance where their breathing slows down as a result of the substance itself. So breathing or heart rate go down. And then as a result, they develop central sleep apnea. We're gonna watch another video about this and we're gonna skip part of it because part of it is for our website that, much like the one that was asked about earlier, is asking you to pay money to learn how to study. So we'll fast forward through that.
So much more. Try it free today.
Blah, blah, blah.
Sleep apnea is a sleep disorder which causes irregular breathing and snoring patterns that can ultimately cause apnea, which is where a person momentarily stops breathing altogether. The inability to get restful sleep can also lead to severe exhaustion. Individuals can have obstructive sleep apnea, central sleep apnea, or features of both. Obstructive sleep apnea is the most common form, and it develops when there's a blockage of the airways. Now, air has to go from the nose through the nasopharynx into the laryngopharynx, through the larynx, and then into the trachea. Somewhere along that path, there might be a blockage in the flow of air. Allergies might cause swelling in the tissues of the nasopharynx, or there might be swollen adenoid glands or tonsils because of an infection. There might be a severe overbite, which pulls the jaw back and blocks the airway. In individuals that are overweight, there could be too much weight in the soft tissues of the neck, which can weigh down the airway, especially when a person's lying down. These problems are most obvious at night, because hormonal changes at night cause the muscles around the airway to become slightly less stiff while sleeping. This means that they're less able to keep the airway open, making it more likely to get a bit squashed or obstructed. Central sleep apnea, on the other hand, refers to the fact that the problem's central or related to the central nervous system. This is where the brain intermittently stops making an effort to breathe for 10 to 30 seconds. The apnea can persist for several seconds even after waking up, triggering feelings of panic and further disrupting the sleep cycle. Central sleep apnea starts with an initial episode of hyperpnea, which is when the brain directs the lungs to start hyperventilating during sleep by increasing the respiratory rate. This rapid breathing causes hypocapnia, a drop in the blood's carbon dioxide levels. When the carbon dioxide levels fall below a certain threshold, the body slips into a state of apnea, making no effort to breathe and taking in no oxygen. This causes the carbon dioxide levels to rise back to normal levels. And then, as the apnea persists, they keep rising to a point where it's called hypercapnia. The really high carbon dioxide levels triggers hyperpnea again, and the cycle starts all over. Essentially, the respiratory system is going rapidly back and forth between two states, first making no effort to breathe and then hyperventilating, with no in between. The most common symptom of sleep apnea is severe sleep deprivation. Interrupted sleep can cause nocturia, the excessive need to urinate during the night, and stress-induced insomnia. The effects are also apparent during the day, because the loss of restful sleep leads to difficulty concentrating, headaches, and fatigue. Apneic episodes are usually preceded by loud snoring, which can interrupt the sleep of other people as well. Sleep apnea on its own is rarely fatal, but it can worsen other health problems. For example, drops in oxygen levels can trigger anginal chest pain and can irritate heart cells, leading to an arrhythmia, an irregular heartbeat. Broadly speaking, individuals with sleep apnea have a higher risk for heart failure, respiratory failure, diabetes, and certain types of cancer. Diagnosing sleep apnea requires a sleep study to help identify episodes of sleep apnea. The more episodes, the more severe the sleep apnea. A sleep study usually involves getting monitored overnight with a polysomnogram. A polysomnogram tracks things like brain movement, oxygen and carbon dioxide levels, vital signs, and outward symptoms like snoring and movement. Treating sleep apnea starts with avoiding things like sleeping pills, alcohol, and other depressant medications because they can relax the throat muscles around the airways and make the airways more likely to collapse during sleep. In addition, sleeping on the side instead of on the back can also help because it creates better airflow into the lungs. For severe sleep apnea, individuals can use a continuous positive airway pressure device, or CPAP device for short. This machine forces the airways open with a steady stream of pressurized air delivered through a plastic face mask or nasal prongs. Used properly, this is really effective, but it requires continuous use. Many people eventually stop using it, finding it annoying or difficult to wear, and so the problem persists. Some people with obstructive sleep apnea can benefit from custom-made oral mouthpieces that help improve airflow during sleep. Sometimes obstructive sleep apnea can be managed surgically, for example, removing large adenoid tissue or realigning the jawbone. These procedures, though, can be complicated because the anesthesia and surgical swelling can both worsen sleep apnea in the short term. All right, as a quick recap, sleep apnea can be due to physical obstruction of the airway or from a neurological malfunction initiated by imbalances in the blood's oxygen and carbon dioxide levels, which regulate breathing cycles. Left untreated, the condition can interact negatively with other underlying health conditions, leading to serious complications. Thanks for watching. If you're interested in a deeper...
So, lots of information there. It's more of an FYI. You're not expected to know kind of all of the underlying etiology, but it is something that's good to know. You know, if you have clients that are struggling with this, because it might be that they need help coping with it. It might be that it's triggering, you know, episodes of other why won't this let me move this over here? It's triggering episodes of other things. So let's say the person wakes up with trouble breathing and that triggers a PTSD episode or an anxiety or panic attack. And so it's good to kind of help the person understand what's happening so that they can, better find ways to cope with it. And also just to help them understand that they're safe and that this is, that this is a physiological thing. So usually people aren't aware that it's happening. They just know that they're not sleeping well. Most people that have been diagnosed with apnea will go to a doctor because they're not sleeping well. And that's when they, get the sleep study and find out that that's what it is. They might have trouble staying awake during the day. They might be fatigued, and it's because they're not sleeping well at night, which is why we would differentiate it from something like hypersomnolence or from insomnia. Moving on. So sleep-related hypoventilation. This is where the person is, instead of having apnea, where they stop breathing completely, this is what's happening where the person is just breathing too slowly at night. So we already talked about our heart rate and our breath slow down a little bit at night. This is where it goes a little bit too far. And then ongoing, the person gets some lab tests while they're sleeping, and we see that their CO2 is too high, or if not available, which is interesting because presumably if they're getting lab tests, you should be able to measure both, but they're having lower levels of oxygen saturation. So this can also be due to something like, a viral infection or encephalitis, but essentially the person's just not breathing quickly enough or not breathing deeply enough when they're asleep. So once again, you would work with the other providers to get lab testing and a PSG, so on and so forth. So we're going to move on. That's all the breathing related. Now we're going to look at the more sort of mental health related, the parasomnias. These are more easily diagnosed by mental health professionals because there are behavioral issues and things that are a little easier to self-report, unlike having to look at oxygen levels. With the parasomnias, you would also want to refer the person for polysomnography, just to roll out other issues and to see what's really happening. For instance, if it's happening during REM phase versus non-REM phase. It's 10 o'clock, so let's take like a 5-minute break. Because I can see that I'm losing some folks, so talking about sleep makes people sleepy. Come back at 10:05. It is 9:59, so right, so let's give everybody a minute here to get back. All right, we're gonna run through these pretty quickly so that we can get to kind of the meat of today. We're gonna start here with circadian rhythm sleep-wake disorders. So this is what we talked about a little bit earlier, where there's some sort of issue with the circadian rhythm melatonin production. This could be things like the person's endogenous, meaning internal or baseline sleep schedule, circadian rhythm is misaligned to whatever their physical environment or social or professional schedule is. This can also be things like, there's been research done where we basically torture people and lock them in, lit up rooms with no windows for a couple days and just see what does their sleep cycle do. So obviously there are people whose sleep cycles don't fit perfectly into a 24-hour schedule. Maybe it's 26 or 27, maybe it's 22, 23. And so as a result, their circadian rhythm doesn't line up with the rest of the world. So there's that misalignment piece. This could also be something due to like shift work, where the person's awake all night. Maybe they're not a natural night owl. Because some people are, right? So we want to differentiate this from people who have a regular circadian rhythm, but maybe they prefer to stay up later. This is where the person doesn't have that preference, or they don't feel good. They're having excessive sleepiness, insomnia, combination of both, and it's causing impairment. So, couple different types here. Let's say the person, they fall asleep late, they wake up late, and again, it's not that they're just a natural night owl. So somebody who has a circadian rhythm like this, but it doesn't cause any disruption in their life, or they don't have any functional impairment. This is only if the person has an actual functional impairment as a result. They're tired, they're having executive functioning issues, that kind of stuff. The second type would be the other way around. They go to sleep really, really early and wake up really, really early. Irregular sleep-wake type, so it changes. Some days it's one, some days it's the other. Non-24-hour sleep-wake type, so this is just the person who, again, has a different circadian rhythm that doesn't fit within the 24 hours. Shift work type is the person who works night shift or swing shift, and they are unable to regulate their sleep as a result. And then unspecified type. So not sure exactly what's going on, but there appears to be something off about the circadian rhythm of the person. Maybe it's changing as a result of seasonal changes. Maybe it's changing as a result of medications, but you're not sure yet. You just know that it's something about the timing of their sleep is off. Specifications. So again, episodic, persistent, or recurrent. How often is this happening? Parasomnias. So these start to get a little bit more interesting in terms of mental health. We won't have a ton of time for discussion today, so if you have other questions, feel free to email me, or if there's anything really pressing, speak up, please, or post in the chat. The first of the parasomnias is non-rapid eye movement, so that should actually say NREM. This is when the person starts to wake up during their NREM cycles, and they might engage or they might experience different things like sleepwalking or sleep terrors, night terrors. So we're going to differentiate this from REM sleep disorders because this is occurring only during non-REM sleep phases. And the reason that's relevant is because different things are happening in the body and different things are happening with the behavior. So with sleepwalking, the person is pretty unresponsive. With any kind of non-REM, the person is going to have trouble waking up. They are not going to be super responsive. And when you do get them awake, they're going to be a little disoriented, a little goofy for a minute, what you might call sleep drunk, that kind of thing. With the sleep terrors, there is some additional arousal that's happening that indicates the sympathetic nervous system is involved here. So heart rate's going up, breathing's going up, they might have sweating, so on and so forth. We're going to differentiate that too from nightmare disorder, which we'll talk about here in a few minutes. So because it's happening during non-REM phases, they don't really remember having dreams, typically because most people don't dream during non-REM. They don't remember the episodes. Obviously, it's causing some kind of distress, which is why they're there. It's not because of medication, and it's not because of some other kind of issue. So if the person is having sleep terrors because of PTSD, but it's only during PTSD episodes, we wouldn't diagnose this. If they're having night terrors or sleep terrors, and it's kind of a main presenting problem, and it's not, only during the episodes, then we would diagnose this. The other thing is that with PTSD, the person will have, what's happening as a result of nightmares, whereas here the person's not having nightmares. They're just waking up with this hyperarousal of the sympathetic nervous system, which is what, lends itself to that fight, flight, or freeze response that looks like a terror or a sleep terror. You are going to specify if it is a sleepwalking type or a sleep terror type. Sleep-related eating, so the person gets up, they just start munching, they don't really remember it. They may or may not actually be hungry, but they're not going to remember it. Sleep-related sexual behavior. So this, you want to really differentiate here between certain types of malingering behaviors. So again, you would use some kind of sleep study to see, is the person actually experiencing sympathetic nervous system arousal? We tend to see the sleep-related sexual behavior more so with passive types behavior. So this isn't a person who is waking up and initiating, or they might initiate, but they, fall back into sleep easily. It tends to be things like masturbation, other types of self-touch, but not necessarily. So it could be a lot of different things, but it does tend to be more passive, and they do not remember the behavior, so on and so forth. The episodes are usually brief, so they're not sleepwalking all night long. It's only happening a couple minutes, sometimes up to an hour, but not often. They are going to be disoriented when they wake up because you're waking them up during that specific sleep phase. Pretty high comorbidity, which makes sense because we know that other mental illnesses can cause sleep disturbances. And it has a pretty high prevalence. So almost everybody sleepwalks at some point in their life, but we wouldn't call it, give them this diagnosis unless it's happening frequently and it's recurrent or ongoing. Same thing with sleep terrors. Sleep terrors are really, really common for infants and toddlers, but they tend to decrease over time. And we don't really see a gender difference, at least in adults. We do with children, but not so much with adults. And again, this isn't the person's having a nightmare. This is the person is waking up, not having a nightmare or a dream, but they're having this hyperarousal of the nervous system. Differential diagnoses. So REM sleep behavior, which we'll talk about. Other types of parasomnias where they have multiple parasomnias. Sleep-related seizures. So could look like a seizure, but it's not. They're not blackout drunk. They're not having dissociative amnesia, even though in both cases the person might not remember where they got or how they got where they are. But it doesn't have to just happen during, this is only happening during non-REM sleep cycles, as opposed to dissociative amnesia can happen at any time. Malingering, of course, if your partner is waking up every night and trying to have sex with you, and then they say it's because they were asleep and they don't remember, let's do a sleep study and see what's actually going on. Panic disorder looks really similar, especially to night terrors. The difference is with night terrors, the person doesn't have necessarily that emotional component. They might have the emotional component when they wake up, where they associate the physiological things happening, the raised heart rate, the fight, the whole fight or flight response. And then they're like, oh, I'm having a panic attack. But they didn't necessarily have that feeling of dread or intense fear right away. Medication-induced behaviors, night eating syndrome, all of those sorts of things. Nightmare disorder, a little bit different here. So here the person is actually having dreams. Everybody has nightmares, but this is when it's happening recurrently and persistently. Typically some sort of sympathetic nervous system activation. So in the content of the dream changes, but it's often around some kind of survival, fight or flight type experience. Unlike with non-REM, once the person wakes up, they are pretty rapidly oriented and alert. So we know that, again, their sympathetic nervous system is activated, but they're actually having dreams. It's causing some sort of distress or impairment. It's not just because of a substance. We know that there are different substances and medications that do cause nightmares, but this would be in addition to that or separate from that. And it's not just because of PTSD. So it could be a result of something like trauma. Maybe they don't meet full PTSD criteria. Or let's say they do have PTSD, but the nightmares are so predominant in the clinical picture that you would diagnose this in addition to PTSD. So a couple different things here. If it happens right when they start to fall asleep, that is a little bit different because people typically should not be falling right into REM sleep. So you would want to do some kind of sleep study to measure what's happening there. If it's due to a medication or a substance use, you would add that, or at least associated with it. If it's something related to a medical condition, or if it's happening during the course of another sleep disorder. So let's say they're having hypersomnolence in addition to having nightmare disorder, you could do both. Specifications here are acute, subacute, or persistent. Notice the change in wording. Instead of saying episodic versus persistent, they're calling it acute or subacute, mainly because the seriousness of what the person's experiencing or reporting feels more acute as opposed to what you might call mild or an episode. That being said, you could still refer to what they're having as episodes. You just wouldn't, code it that way. Features. So we know that the sympathetic nervous system, part of the autonomic nervous system, is involved. Sometimes the person will wake up immediately before the nightmare instead of after. So you would again see this during the sleep study. You would see the heart rate go up and you would see the person sort of suddenly arouse and then they fall back asleep and have a nightmare, and the nightmare is related to that nervous system arousal. It does tend to happen more during stage 2. So as we're getting into REM sleep, especially if it's related to an adverse event or trauma, but it doesn't have to be. Typically, during the nightmare, the person is not talking or moving around. If they are, it could be a different sleep disorder. It can happen, but it's rare. Tends to increase over time, although it's difficult to measure because, with children or infants, it's usually the parents reporting it, because the actual client might not have the language of it, the language to describe it, as opposed to when people are able to start self-reporting. So it might look like it's happening more frequently, but we don't actually know. The other issue with the prevalence is that statistics about nightmares don't differentiate between nightmare disorder and other things that cause nightmares like PTSD. So lots of trouble there with actually diagnosing, or rather not diagnosing, but with gathering statistics about it. And again, most people have nightmares sometimes, but nightmare disorder is when it's actually just really recurrent. There aren't differences in the prevalence by culture or gender. However, the actual content appears to be different. So it's going to be things that stress people out more based on culture or gender. So for example, cisgender females in our culture tend to report more nightmares related to things like sexual assault or losing a loved one, whereas cisgender men in our culture tend to report more nightmares related to violence or aggression. Both still have this fight, flight, or freeze type component, or this sort of trying to escape the situation type component, but the actual content or the meaning to the person might change based on their gender or culture. Risk factors. So, of course, history of adverse events. They say sometimes trauma, but not necessarily. I don't totally agree with the wording in the DSM there, because obviously if it's affecting the person to the point where they're having nightmares, I would call that a trauma, even if they don't meet full criteria for PTSD. Personality disturbances. So this could be things like having a personality disorder, but it could also just be things like having traits of a personality disorder without actually meeting full criteria. Other types of psychiatric diagnoses like anxiety, depression, really anything that's affecting the sympathetic nervous system that's going to cause it to go a little haywire while the person's sleeping. There does appear to be a genetic link, both due to twin studies and with first-degree relatives. And we know that things that help with the sympathetic nervous system can protect against further episodes or developing a chronic course. So with kiddos, that means waking them up and engaging in some kind of soothing. For adults, it can mean that too. It can mean self-soothing. Maybe the person wakes up and engages in some kind of calming behavior. They might do breathing exercises, a lot of that same sensory motor or psychosomatic work that you would do for something like trauma or anxiety or panic attacks. It can mean some kind of physically soothing behavior, like using a weighted blanket, having somebody rub their head or their back. All of these things that kind of lower the sympathetic nervous system and put the person back into a sympathetic or a parasympathetic state can help prevent further nightmares both that night and prevent the person from continuing to have nightmares in subsequent nights. Which leads us then to REM sleep behavior disorder. So here, unlike non-REM, it's happening during a different sleep stage. A couple differences between this and non-REM. So with REM sleep disorder, the person wakes up and they are usually fully awake as opposed to disoriented, which is because of what's happening during REM sleep with the body, with the brain. The person basically is in this phase, they might start talking, might not be understandable, but they're talking and they have complex motor behavior. So when we talk about complex motor behavior, it's not just they're twitching or their hands are moving. This is the person is actually sitting up, walking, using their hands to do something. It might appear to be goal-oriented. Maybe they're grabbing their phone, maybe they're grabbing at the other person. There's some kind of complex behavior that's more than just, moving the legs, stuff like that. It might also look a lot like dream enacting behaviors. So let's say the person is having a dream where they're running. They might start engaging in body movements that look like running. People's dogs do this. It's super cute. They start barking or, kind of moving their legs, chasing bunny rabbits in their sleep. Same thing happens, but it's with people instead. But everyone has seen that happen, probably with animals or with a partner. It does tend to be disturbing to the person because maybe they're engaging in movements associated with the dream and it's not a pleasant type of dream. So that's where you see the more aggressive type behavior or sometimes even violent type behavior, but the person's asleep and they don't remember it. So obviously it's happening during REM phase, which usually starts about 90 minutes after they fall asleep and then more frequently during later portions of sleep. So you would want to do a PSG here and see what phase is the behavior actually happening in. We already talked about criterion C and then criterion D. You could be a couple different things. So first, let's just say atonia. It could be due to something because of another neurological issue that causes disturbances in sleep phases, something like Parkinson's, or where we just, we do a PSG and we see that it's just happening during their REM phase. Atonia would mean the temporary loss of movement or muscle tone. Not the same thing as cataplexy, where the person just goes completely limp. Atonia is kind of more of an in-between. It can be described as sleep paralysis. The person just doesn't move. So here, typically during REM, a person has atonia, but here the person's not having atonia. And so we would be able to differentiate based on the PSG recording. We're like, okay, they're in REM sleep. They shouldn't be moving, and yet they are. So behavior is causing some kind of issue, right? That's why they're coming to you. Maybe the person's hurting themselves. Maybe they're hurting someone else. Maybe they're having a nightmare and they start hitting somebody in the face, or, something's happening here where it's causing some kind of major distress. It's not due to substance. It's not just due to another medical condition, although it can be associated with medical conditions like we talked about. And it's not just because of another mental or medical disorder. So they could have PTSD, but then in addition to that, in addition to the actual nightmares that are associated with PTSD, they're actually moving, talking, so on and so forth. So the dream and acting behaviors, we talked about that. Pretty low prevalence, depending on the criteria that are used. The onset can be gradual or rapid, so it either happens all of a sudden or it gets worse over time, but it does tend to be progressive, meaning that it happens more frequently and more intensely over time. It is associated with psychiatric comorbidities, possibly due to medications. So, Liz, you said it can't be due to medications or substances. What's that about? Basically, the data shows an association, but it's not clear as to why. So it could be that, let's say, the mental health issue was masking some sort of underlying issue. So like with depression, there are sleep disturbances, but then you get treatment for the depression and all of a sudden you're like, hey, here's this thing that's happening during sleep. It wasn't happening previously because the depression itself was affecting the REM cycle. But now that the depression is being treated, we're seeing, oh, look, there's something wrong with the REM cycle in addition. Same thing with bipolar. You know, if the person's having a manic episode, you treat it, the manic episodes go away, and then you see this other sleep issue emerge. So it's not clear in the data whether it's due to the medication itself or if it's due to, you know, there just being an underlying problem that the medication unmasked because the first presenting problem is being treated, or both. We don't know. Differential diagnoses, so other parasomnias. Again, you would use a PSG to see, is this happening during REM versus non-REM? Another way to tell is what they're like when they wake up. If it's non-REM, remember, they're going to be kind of disoriented and a little goofy when they first wake up. If it's happening during REM, they're going to be, you know, they're going to be more alert. The other thing is if they have regular atonia, then it's probably not a REM sleep behavior disorder. Nocturnal seizures, so it might look a lot like this, where the person talks a little bit. Maybe they start engaging in some sort of aggressive appearing behavior. You would want to get an EEG and a sleep study, a PSG, to monitor and differentiate between the two. Make sure it's not due to obstructive apnea. So the person stops breathing, they wake up in a panic, they hit the person closest to them. Not the same thing. Another dissociative disorder. So this is when we talked about dissociative disorders, but this could also be people that while they're asleep, maybe they wake up. And so you would see this again from a sleep study where they actually are fully awake, but they go into a dissociative state and they engage in some kind of behavior. Maybe they have a dissociative fugue, that kind of thing. And then, of course, malingering. So if somebody is reporting problematic behaviors and they say it happened because they were asleep, let's get a sleep study and make sure that that's true and they're not just engaging in problematic behaviors and want to have, you know, some kind of reason to explain why they're engaging in that behavior. Restless leg syndrome. Lots of people talk about this. Most people that talk about it may or may not actually have it, but we will see. So the reason this is in the sleep-wake disorder category is because it appears to have a neurological link, and it appears to have something to do with various sleep and wake stages. So the uncomfortable feeling in the legs, this is often described as some kind of burning or creeping or crawling. It happens worse when the person is in a more parasympathetic state. So they are resting or they are inactive, heart rate's down, breathing is down, and all of a sudden they just get these awful feelings in the legs. And if they start moving the legs, or if the legs start moving on their own, that appears to relieve the burning sensations, or, you know, whatever the uncomfortable sensation is. It also gets worse at night, or it only occurs at night, which again kind of speaks to the neurological component. So we have our 3x3 again. It's happening at least 3 times a week, and it's happened for at least 3 months. It's causing significant distress or impairment. So maybe the person's not able to sleep as a result, or it's causing distress or impairment because it's upsetting whoever they're trying to sleep next to. It's not due to another medical condition. So it's not because of like diabetic ischemia. It's not because of arthritis. Leg cramps are really common, especially when a person's trying to sleep. It can happen during pregnancy, but you want to, again, differentiate from the leg cramps. And it's not because of a behavioral condition like they're uncomfortable or they're tapping their leg because they have anxiety or they're stimming. It can look a lot like stimming, but the difference is that it's not necessarily purposeful. Again, not due to medication or illicit substances, as always. So pretty high prevalence. Onset tends to be in adulthood. Not a lot of understanding as to why that happens, but it does decrease over time, which lends itself to, this theory that it's related to the autonomic nervous system, because we know that people tend to experience decreased autonomic arousal later in life and increase sort of in early adulthood. Onset during pregnancy is higher, and if it goes away after pregnancy, you would get rid of the diagnosis. It's associated with periodic leg movements in general. So some people, when they're falling asleep, their legs will twitch a little bit, or even when they're awake, their legs will twitch a little bit. So there is a high association there. Folks that experience the leg twitching or having movements tend to develop restless leg syndrome. You can also use a sleep study to monitor if it's happening, because the person may or may not be aware that it's happening. And there is an association with comorbidity, which again lends itself to this, this nervous system explanation. So things like depression, anxiety, PTSD, schizophrenia, all the things, any kind of psychiatric comorbidity that leads to sleep disturbance can be associated with developing restless leg syndrome. So really, really well studied because of the high frequency. The etiology here is we know that there is this link between dopamine and the dopamine system. And we know this because it tends to happen in folks that, there are different medications that affect dopamine. So for instance, a person with Parkinson's, we give dopamine medications that increase dopamine in the system, and they develop schizophrenia-like symptoms, and vice versa. So folks with schizophrenia, we give dopamine antagonists, which increase Parkinson's type symptoms. And so we know that there are these movement disorders that happen as a result of the dopaminergic system. There's also issues with iron metabolism. And so you would want to have, again, lab work, sleep studies to see what's going on there. The iron metabolism piece could account for some of the changes during pregnancy. And then the risk factors, if you look in your book, there are tons of specific genetics that have been implicated. And lots of research there. So somebody asked in the chat the difference between REM behavior disorder and nightmare disorder. So the difference is with REM sleep behavior disorder, the person may or may not actually be having dreams or nightmares. Or they could even be having positive dreams, but there's nothing about the content or frequency of dreaming during REM sleep behavior. REM sleep behavior is just the person's having these behaviors during that sleep phase, but there's no actual criteria about whether or not they're dreaming or what they're dreaming about. Whereas nightmare disorder, specifically, the person's having nightmares. Does that make sense to the person who asked? Oh, and there's a big puppy. Yay. Glad I checked the chat. Next, we have substance or medication-induced sleep disorder. So here, as always, the person has some kind of sleep problem as a result of medications or substance use. There can be issues with specific types of medications, and you want to make sure that the medication is actually, like in criterion B2, that the medication is actually etiologically linked to some kind of sleep disturbance. So for instance, an antidepressant that increases arousal, like sympathetic arousal, might mean that the person has trouble sleeping. Sometimes it's a matter of taking the antidepressant in the morning instead of at night. But you also want to differentiate and make sure, like, okay, I put this person on an antidepressant. Is it just a sleep issue, or have I now induced a manic episode and the person is bipolar the whole time, but we don't find out until we started medication. On page 405, they have a whole list of different codes based on the substance itself. And so you'd want to read a little bit more about that and see what is the substance that's causing it and why. You would specify, is the medication leading to insomnia? Is it making them drowsy? Is it happening only when they take the medication, or is it happening during withdrawal or discontinuation? There are a lot of substance withdrawals that can cause issues with sleep. They can cause nightmares, cause disturbances to both REM and non-REM phases. Certain withdrawals, particularly alcohol and opiates, require monitoring for various reasons, but one of the big ones being the sleep issue that can then lead to psychosis, issues with breathing, the heart rate slowing to the point of death, seizures, so on and so forth. Other specified. So these are in the end of this section of the DSM, although they might make more sense if we were to put it up near, actual insomnia and that kind of thing. But they are here because for the sake of consistency, we always put specified and unspecified at the end. So other specified insomnia. We talked about this earlier. If they have a brief insomnia, less than 3 months, use your clinical judgment to decide, is it brief due to an acute issue like a stressor, or do they have insomnia and they're having recurrent episodes that just happen to be less than 3 months? If the person has insomnia, but or they don't technically meet the criteria for insomnia because they only have 1 or 2 of the symptoms, but not all of them. Kind of the same as most other specified that we've talked about in the past. Unspecified, so same thing. They don't meet full criteria. We don't know if they meet full criteria. We don't have enough information. Lots of consistency there with all the other unspecified diagnoses. Other specified, hypersomnolence. So this could be due to not meeting full criteria, but it could also be due to a specific reason. So for instance, Klein-Levin syndrome, I know we talked about this a little bit in the eating disorders, but this is something that can happen following an infection where the person is sleeping all the time. And so you'd want to differentiate if that's what they've been diagnosed with, then you would say other specified hypersomnolence disorder, due to Klein-Levin syndrome. Unspecified, as always, doesn't meet full criteria, unknown if it meets full criteria, or you don't have enough information. Maybe you're waiting for those lab tests or you're waiting for that PSG because it might take a few months to get them in to see a sleep specialist or a neurologist, and so you just don't know yet. Other specified. So, doesn't meet full criteria of any of the other diagnoses, but they do have some kind of issue. So they've done a PSG and we're seeing that they're having these repeated arousals, or maybe you just haven't got the PSG yet and they're reporting repeated arousals. It could be related to something like Parkinson's or another neurological issue. Maybe we haven't gotten labs back yet, or we just don't know what's going on. And unspecified means does not meet full criteria, we don't know why, and we don't want to say. All right, so let's take another 5 minutes, and then we will start on the sexual dysfunctions, paraphilias, and gender dysphoria. And if there are other questions, go ahead and put them in the chat, and I will answer them when we get back. All right, so I'm gonna give everybody a minute to get back. Two questions that popped up in the chat. So one was about something similar to restless leg syndrome, but with the arms instead. The answer to that is I have no idea. I am not a neurologist, not a sleep specialist, but if there is something like that that's causing, you know, a level of distress or impairment, I would definitely get it checked out, because it could be all sorts of things, right? It could be a pinched nerve, it could be some kind of general discomfort, it could be some kind of pain related issue. And so I would definitely, you know, go to somebody and see what's going on there. The second question was about unspecified erectile disorder. So there is, in your DSM, there is an other specified sexual dysfunction and an unspecified sexual dysfunction. So that's where you would put something like that. So any of the other diagnoses, again, that don't fit full criteria or haven't been, haven't been happening long enough to meet the full criteria. And then regarding case studies, so I sent out an email about the case studies. We're probably not going to review them this week. First, because we don't have time. And second, I moved the deadline back to next week just because the classes were uneven in terms of what we were able to review. And I didn't want people to have to, feel pressured to turn something in regarding content we haven't actually reviewed. If you did them, awesome. If you didn't do them, you don't have to until next week because, we didn't get to everything. So. All right, so sexual dysfunctions, paraphilias, and gender dysphoria. Let's start with the first problem with this part of your book. Any ideas? Anybody want to volunteer? There's no wrong answer here. I cannot hear. Hold on, this is funky. Something is up with the speakers. That's a fun game. So I saw that Greg and Megan both turned their mute off, but I cannot hear you. All right. Be right back.
Now we can't hear you.
Oh, I can hear you though. Can you hear
Hey, we can hear you now. Yeah.
It's like an old Nintendo. Just press all the buttons and something will Cool. All right. So first problem with this part of your book.
I think it's really interesting that gender dysphoria and sexual dysfunctions are in the same group. And
Yes.
paraphilic disorder, like that seems inappropriate to me.
There is. They are not in the same section in the DSM, and you're right. It is not necessarily. These things are not necessarily related. They can co-occur, obviously, but so can everything else. So putting all of these together just kind of seems like we're going to lump everything related to sex into one thing, even though gender dysphoria has nothing to do with sex. I didn't read the book. So that's kind of the main thing here. And so I want to make it very, 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 very clear with this section that sexual dysfunctions and gender dysphoria are very different from paraphilia, and we will talk about why, but they should not be confused. And a lot of this, could be due to these biases we have in our culture, these ideas we have that people that have gender dysphoria, which again, not even, not all transgender people experience dysphoria. We talked about that before, or, this cultural idea that normal variations in gender are somehow paraphilia in some way. Same thing with sexual dysfunction. So there's a lot of bias around various sexual dysfunctions that maybe there's something psychologically wrong with the person and that they have some kind of paraphilia issue. And so we really want to tease out those cultural biases from the actual criteria. And so we'll be reviewing the DSM criteria while we look at the info provided from the book. So what is normal sexuality? Who decides and why? Any ideas here?
Well, it's probably the old white men that wrote the DSM get to decide what's normal.
Well, yeah. And that's where we see a lot of those changes with the DSM happening. So what we know from history and what we know with, sort of cross-cultural studies is that sexuality looks different in all sorts of places, and it looks different across history. And what anthropologists have found is that the last few hundred years are more abnormal, at least in Western cultures, because historically and across cultures, we see variations in gender, we see normal variations in sexuality, and this idea that there's a binary gender system and that there's only certain types of sex that are considered normal or morally appropriate, and that kind of thing is a really new idea in historical context, a fairly recent development, and very specifically culturally bound, mainly in Western and among certain religious groups and that kind of thing. So fairly new idea and not universal.
Liz, now you're really breaking up.
Oh no. Time to switch the internet. All right, I think I fixed it. So we will skip those. Talked about this. Lots of research on sexuality, at least over the last 100 years or so.
Can you hear us?
Mhm.
You were breaking up like the last maybe 2 or 3 minutes. We caught very few words.
Okay. So basically, how about now? All right, cool. So basically, we were talking about how what we consider to be normative sexuality now is a fairly recent historical development and very much a culturally imposed development over the last several hundred years and within the context of Western culture and specific patriarchal type cultures and patriarchal type religions. Outside of those confines, we see lots of broad ranges of sexual behaviors. And so a lot of the stuff that we talk about today might be kind of uncomfortable. And, if we are sticking with some of those philosophical discussions we had at the beginning of the course around mental disorders being anything outside of normal or normative experiences, we might, we have to kind of look at it within that context. So we know that there are lots and lots and lots of variation in what we consider to be normal or normative sexual behaviors based on things like gender, based on things like faith communities, based on things like age, all that sort of stuff. One thing that's really interesting, so has anyone taken the survey, usually around high school, where they asked about things like drug use, sex, smoking, so on and so forth? So this is done every 10 years. And interestingly enough, what we have found, and I'll have to look up the name, so it's like adolescent high risk behavior, something or another. So this is a survey that's done nationally in the United States every 10 years. And despite common beliefs that kids these days are doing this or doing that, or they're drinking too much, they're partying too much, they're having sex too much, there's actually been a decrease in those behaviors over the last 20 to 30 years. So for example, we have seen the average age of first intercourse go from around 15 to around 17 between the generations. So Gen X folks, the average age of first intercourse was around 15. For Gen Z, it is 17 or later. Same thing with drug use, same thing with alcohol use, same thing with cigarettes use. So despite what people may believe about kids these days, they're actually kind of squares compared to the rest of us. And we were much worse than they are. So just throwing that out there. What is normal sexuality? So this is based on specific research done in around the 70s, 50s through 70s by a guy whose name starts with K, that I don't remember off the top of my head. Anybody remember? And
Kinsey.
what was it?
Kinsey.
Yes. So the Kinsey Institute. Lots of research done. pretty much the first major sexology research in the United States, but he's, the work has been done all around the world. And what they were really trying to do is take sexuality and apply a psychological lens, but also an anthropology lens, a sociology lens, really just gather data. So Kinsey's work is interesting because they applied things on scales. So as opposed to seeing things as very binary, like attracted to men or women or both, they started using these Likert scale type questions. And so you'll see these different percentages, right? So pretty normal, what we consider to be normal here is looking at how many partners the person has had, how frequently they have new partners, and how often people experience homosexual attraction or behavior, which obviously are not the same thing, but Kinsey links the two. Oh no, not again. What's happening? Can you guys hear me? All right, I got a sign that told me my internet was unstable. So we also have this idea in our culture that older adults do not have sex. That is not the case. While there is a decrease due to physiological changes and also just physical health problems, sexuality should really be seen as kind of a lifespan approach, beginning with puberty and all the way through older adults. We do talk about sexuality in children, but it rarely is actual sexuality. For instance, Freud talked a lot about sexual behaviors in children, but he used the word sexual to refer to anything that was physical pleasure, physical sensation seeking. He didn't mean it. He didn't use the word sexual to refer to things the way that we refer to sexuality. So lots of misunderstandings there. If you read Freud's direct work as a primary source, you will see that it's not about sex as it is just about taking pleasure in the body and different types of pleasurable behaviors. So for the sake of this class, when we talk about sexuality, we're referring specifically to puberty and beyond, and behaviors that are for the sake of sexual gratification, as opposed to things that are just physically gratifying. For instance, you might have an 8 or a 9-year-old or prepubescent person that experiences orgasm, but they don't quite differentiate between just anything that's physically pleasurable in general versus things that are sexually pleasurable, which, culturally we have all these other expectations or ideas around what is sexually pleasurable versus what is just physically pleasurable. Masturbation. Lots of changes here or lots of differences here based on cisgender stuff. Some of this could be due to people just having more normative type behaviors. Some of it could be due to how they experience masturbation, how they define masturbation. So for instance, there are lots of people who masturbate but don't reach orgasm, so they might not actually consider it to be true masturbation. Some of it could also be due to gender bias in reporting and people having embarrassment or just not being as much of a socially acceptable behavior for cisgender women. And so we do see a reporting discrepancy. Kinsey's research continues to be used, even though a lot of it is like 50, 60 years old. So, expect to see some changes in this data over time and depending on the researcher that you're looking at. Some cultural differences here. I found a typo and it's not my slide. So there. So again, based on older research, when we look at actual attitudes about sex, there are a lot of differences that are based on cultural norms and not necessarily based on what would actually be considered normative behavior across time and across other cultures. There's different ideas about this. Some ideas are that differences arise early on when people are first developing their sexuality. So we know that cisgender male children tend to experience masturbation more frequently because they have these physiological experiences that they can't necessarily control. So maybe they're experiencing like physical arousal when they don't want to be, or they're experiencing things like nocturnal emissions. But essentially, because of those physiological things, they might be more prone to masturbatory behavior. And because they're more prone to masturbation, they are able better able to differentiate between sexual pleasure and emotional connection earlier on than women. Whereas for a lot of cisgender women, historically in our culture, their first experiences of sexuality tend to occur relationally, like with a partner, as opposed to by themselves. And so it could be that we develop more of an association there than men do, who are better able to then distinguish between pure sexual stimulation and emotional intimacy, all that kind of stuff. That idea originates with Nancy Friday. She was a sexologist who started her work in the 70s, continued through the 90s, and she really studied like the sociology of sex and gender to figure out where do these differences really come from. There are lots of other theories. That's just one of them. We also see changing attitudes over time. For instance, acceptance of homosexuality, bisexuality, or pansexuality. Lots of changes over time. And a lot of the changes that we're seeing now are more in line with what we've seen historically prior to the last several hundred years. For example, homosexual behavior has been very, 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 very common for a very, very long time, but it wasn't necessarily considered a sexual identity. For example, in medieval European, Western, including Christian cultures, you might have perfectly acceptable homosexual behavior because it was seen as an alternative to having sex outside of marriage, which could result in an unwanted pregnancy, illegitimate children, so on and so forth. And so you might have folks who were engaging in romantic or sexual relationships with same-sex peers, but they didn't necessarily identify as homosexual because that's a relatively new concept. We still see this in cultures now, like in certain Latin American cultures, it is considered more masculine to engage in homosexual behavior if one is what we would consider to be a top as opposed to a bottom. And the reason for that is, again, related to not wanting to have extramarital sex that could result in something like a pregnancy, but also there's this element of dominance over other men, pretty highly linked with machismo culture and all of that, as opposed to people who are considered bottoms, the way that we in Northern Hemisphere, Western culture would call it, are considered less masculine and sort of seen even lesser than women in that kind of gender hierarchy, because they are less, they are being submissive to another man as opposed to engaging in heterosexual behavior. So we want to differentiate between actual behavior versus identity. So self-schemas, beliefs about one's own sexuality. We talked about this a little bit already. Culturally, we have lots of weird ideas about sex. We have lots of beliefs about sex. And so what is considered to be normal and not normal really just depends. This is where things get kind of problematic in your book, is that they have this whole sort of introduction on cisgender men versus cisgender women that we now know is pretty outdated, and also very much normative based on culture, place, time, so on and so forth. There are some cultural issues around different taboos. So some of this is not nearly as common as your book would have you think. For instance, this issue with Papua New Guinea, when that behavior was originally described, it was described by anthropologists who were coming from a very specific lens. And what they were describing was only happening among certain families and certain situations, as opposed to the whole culture widespread. And so there was some wonky stuff there where, we form these biases against certain cultures and think, oh my God, they're having sex with children, when it turns out that that's not, it's still happening, but it's not happening at the level that folks that were reporting it really got people to think. There are also different taboos around things like incestuous behavior, where you might have marriages formed between siblings, between cousins, and those types of marriages, the marriage might be expected to be consummated, but it was still understood that those people might have sexual partners outside of that marriage. So the marriage itself, for instance, in ancient Egypt, the marriage itself might be done as an alliance between various family members or sects of a family. But it was a marriage in name only. Maybe they would reproduce, maybe they wouldn't, but they were allowed and expected to have relationships outside of that marriage. And so we want to be really careful with how we talk about these things and whether or not there's an actual sexual relationship or if it's some kind of cultural behavior outside of that.
So if in our culture, we would expect oral sex between a teenager and a young boy, that's considered abuse, and we would classify that as a trauma. They don't seem to classify that as a trauma. It seems to be like a positive thing in their culture, that it's helping people develop. Do we still see the same outcomes where like trauma responses or stress responses in those children, or is the paradigm that they're coming from a protective factor for that?
So again, the reported behavior from the folks that studied it originally stated that they believed that this was behavior that was being encouraged or behavior that was seen as positive. Whether or not it was actually seen as positive by this culture, we don't really know, because it wasn't as widespread as the original researchers stated. And there wasn't really a lot of follow-up research to say, is this actually causing any kind of trauma for these folks? So a few different things that can come up, like we talked about a few minutes ago, whether or not the behavior was actually seen as sexual can make a big difference within the context of the culture. Whether or not the behavior was just seen as some sort of exploring. So in the India example, lots of children masturbate near each other, and it's not necessarily sexual, because for them, it's not necessarily about sexual gratification. They're just exploring their body the way they explore other parts of their body, or the way that they explore other bodily functions, like going to the bathroom, or nudity, or picking their nose. So for example, I had a client about 10 years ago where they came and were freaking out because their kid was putting marbles up their other kid's butthole in the bath. Kids were 3 and 5. And they are convinced that this was some sort of like molestation behavior or victimizing behavior. Turns out the kids were also shoving peas and marbles in all of their other holes. So nose, mouth, ears, so on and so forth. And so the conversation then became about like, is the older child doing this for sexual gratification? Are they using the other child's body for sexual gratification? Or are these just two kids who see a hole, look at it like every other hole, and they're just exploring the hole because they don't know the difference between this hole, that hole, the nose, the mouth, the ear, so on and so forth. And so in this case, I would say that if it's being used for sexual gratification, that would probably be more traumatic than if it's being used as some sort of physiological thing. Because we have cultures where people partake in drinking blood, other fluids, in which case the semen would be just considered another bodily fluid. But if we see it in cases where it is used specifically as some sort of abuse situation or some sort of major power difference, then, obviously we would look for signs of trauma. So it really just depends, with the caveat that some of this research wasn't good research and was reported in really problematic ways that wasn't actually reflective of the people that were being studied. Especially with Papua New Guinea, there was a lot of anthropological studies early on that were there to basically justify colonizing the area by exaggerating certain behaviors and adding some really strong moral judgments to justify these people are savages and we need to go do XYZ. So take it with a grain of salt on how often that's actually happening. We are going to skip over this because there's not a lot known about the development of sexual orientation. And so the book tries really, really, really hard to present sexual orientation as this not normative experience, when we know that, again, over time and across cultures, tons of different sexual orientations exist. And this idea of heterosexuality as an identity, as opposed to just a behavior, is a relatively recent development. All right, so actual sexual dysfunctions in the DSM. So these are anything that the person is having issues with desire, arousal, physical arousal, psychological desire, and or orgasm. There can be pain, it can be issues with achieving any of those three things. And there has to be some kind of impairment under stress, right? So lots of people might just have a naturally lower libido than others. It's not necessarily a sexual dysfunction, and you wouldn't diagnose it unless it's causing the person an issue or they're coming and complaining about it. Or if it's all of a sudden, let's say they have a sudden change in libido, then we would look at potential diagnoses. So for those that have your DSM, please turn to page 423 because I want to kind of compare what the DSM says with what your book talks about. So the way that your book categorizes sexuality is first, the person experiences some kind of sexual desire. They then experience both psychological arousal, but also physiological arousal. So changes in blood, changes in lubrication, changes in breathing, heart rate, so on and so forth. Does anyone not know what it means to be sexually aroused? Please don't make me explain it to you. I have a really awkward book. This is great. Someone, I have a coworker that found this. I think I showed this to you guys last week, or I might have showed it to my other class, but I have a coworker that found this lovely book from 1973 about where did I come from? And it's illustrated. So if you really want, I will read it to you and I will show you the pictures, but I'm assuming that you all know what it means to be sexually aroused, but just for posterity's sake. They got this at the library stage, or at the library sale, by the way. Yeah, really uncomfortable. Brief period occurs before orgasm. That is what we consider in Western culture to be normative before the person actually reaches orgasm. So they're aroused during this time, but they haven't actually reached orgasm yet. They reach orgasm and then they have the decrease in arousal, again, considered normative. There are people who continue to be aroused after orgasm, or they reach a plateau phase again and they have multiple orgasms. So this idea that there is a normative way to engage in sexual behavior in of itself is a little bit problematic, especially as we learn more about the human body. We learn more about what the nervous system is doing. We learn more about other cultures, other ways of engaging in sexual behavior, so on and so forth. I also want to point out that this would be considered normative sexual behavior for heterosexual sex only. And folks that are engaging in homosexual behavior or pansexual behavior, you might not have these exact same phases. Prevalence. So anything that is outside of this specific phase paradigm of sexuality is considered to be a sexual dysfunction. So if the person gets stuck in arousal, they're not able to reach orgasm, or if they get stuck in plateau, they're not able to reach orgasm, they get stuck in desire, they can't get physically aroused, any of those things are considered to be a dysfunction within this idea of this is what sex is supposed to look like. So pretty high prevalences as a result. Lots of different things that can happen. So lifelong versus acquired. There are some people who just orgasm less than others. There are some people who become physically aroused less often or less intensely than others. And that's something we would be considered lifelong. And to me, I would consider that just to be a normal variation in sex because everyone has, everyone's bodies function differently and people just have, different ranges. Acquired would be a little bit more concerning. So let's say they are used to having certain types of arousal, certain abilities to reach orgasm, frequency of orgasm, all that kind of stuff. And then all of a sudden it changes, or it changes progressively over time and it causes distress to the person. Like, why is my body doing this thing it didn't used to do? That's when we would really look at a dysfunction. Generalized versus situational. So this could be the person has trouble with arousal all the time versus they only have trouble with arousal during certain social situations or certain partners. It could also be certain times of day, based on diet, based on sleep, based on stress, all that stuff. Then there is issue with having some kind of psychological factors. So let's say the person has trouble reaching orgasm when they're stressed, but they don't when they're not stressed. Or if it's a psychological factor combined with a medical condition. This could also be things like medication. Lots of SSRIs cause issues with sex. So an SSRI can cause issues both with libido or desire, with physical arousal, and with reaching orgasm. Again, it depends on the person and just their body chemistry and what's considered normal for them and what changes for them. So these do not go in the same order as the DSM. Let's talk about this. So male hypoactive sexual desire disorder. What does that mean?
They have lower sexual desire than like the baseline or whatever is considered the baseline. I'm not quite sure how that's determined, but
yeah, exactly. And so this is one of those things that is really, really problematic because now we're starting to consider just being asexual a normative variation in sexuality. There are people who are just less sexual than others. And so I would ask the question, is it lower than your baseline or is it lower than what you think the baseline is for other people? Because you will get, especially with younger folks whose only sexual education or sexual experience comes from things like pornography, for instance. They might come to therapy and say, I don't want to have sex as often as I see in movies, or I can't maintain an erection for 3 hours like I see in pornography. And you're like, okay, well, that's actually normal. And what you're viewing is what's not really normal. You know, you're seeing something on, you know, a different range. So this is a fairly problematic. And if it's something that the person is complaining about, you would still give them the diagnosis. So this person isn't as sexual as they would like to be. Maybe that's something we need to look at. Maybe there's an underlying trauma. Maybe it's just a mismatch with their partner, all that kind of stuff. Erectile disorder. So this is different. The person has libido, but there is something happening during physical arousal itself. And it's kind of the most common thing, at least for cisgender males, that will come into treatment for. The reason I'm flipping through my DSM is because these all have different names and codes compared to what your book has. Part of this is because your book sees things much more generally, and your book is really based on what the writers consider to be normal sexuality, whereas the DSM is based more on what is actually normal and what is actually, or at least what is seen as more scientifically normal. It's also based a lot on statistics. So we might call something abnormal just because it's rare. And so it kind of adds that stigma, even though we know that, for instance, with older men or men that are on certain medications or have certain diets or things like that, it might be really, really common. So statistically, it happens a lot, but because it causes distress, or if it's happening frequently enough that it's causing distress, or it's falling outside of what this person's expectations are, we would then give them the diagnosis. Very similar here for female sexual interest or arousal disorder, although you will notice the gender differences. So with male, they don't give a lot of specifics. Whereas with female, there's all of this sort of additional pathological view of what female sexuality should look like. And again, we're not talking just about the person has sexual trauma. This person could just be asexual, which we would now consider to be a normal, a more normative sexual identity. Or if they're complaining about it, or if it is due to some kind of trauma, then we would, we'd give them this diagnosis. So it really comes down to whether or not the person's okay with it, or if the person's had some kind of marked change. Maybe they did used to have much more frequent sexual arousal or desire, but now they don't. And so we would look at why and see what's going on there. Female orgasmic disorder. not the same thing as issues with ejaculation. A lot of the diagnoses here could use some updating because we know now that men can orgasm without ejaculation and vice versa, whereas there are multiple types of female orgasms, same kind of thing. It could be clitoral, it could be vaginal. And so here, what we're looking at is both or one or the other. And it has to be based on issues with, so basically here the person is getting aroused, they are physiologically aroused, but they're unable to finish orgasm. The fact that this is fairly common, again, lends itself to maybe this is just a normative sexual experience as opposed to an actual disorder. So once again, you would only give this diagnosis if the person is coming to you and saying, like, I'm having this trouble that I didn't have before, or I'm having this trouble and it's really causing an issue for me. And therapy-wise, you might work with the person around psychoeducation, like, okay, well, where are you getting this idea that you're supposed to orgasm this often or this frequently, or in this way or in that way, and kind of work with them around their expectations. Or you might see if there's a change and figure out what's changed and if there's some sort of underlying issue. They do say that it's not caused by distress or significant stressors. That's where the statistics get a little bit sticky because the statistics don't necessarily ask about cause. And so there's just a lot of weird research stuff that's happening with these. Primarily because the research samples tend to either be, number one, people that are coming in for a problem, and so it might be over exaggerated because it's people that only consider themselves to have a problem. And then number two, in the research that's been done with general population, there's a lot of shame and stigma, and so people don't necessarily answer as truthfully because they don't feel comfortable. Premature ejaculation. So two very different things here. Ejaculation occurring within 1 minute of penetration. Not the same thing as before it's desired. Normative sexual experiences, right? For some people, less than a minute might be fine. If the person is masturbating, less than a minute might be fine. Where it becomes an issue is if the person doesn't mean to, or they're not trying to reach orgasm and they do. Or they have ejaculation without orgasm and then they can't reach orgasm. So again, it's pretty prevalent. And that lends itself to think that maybe this is not really a dysfunction, but more just a normative sexual experience. Because sex is complicated. There's lots of different things happening in the body, and they don't always line up. Genitopelvic pain or penetration disorder. So there is a lot of research indicating that this is related to trauma, which makes sense, right? So the person is engaging in, and it doesn't just have to be that they had sexual assault trauma. It could be that they had any kind of interpersonal trauma. The reason, or another reason why we think that is because there are links with other types of pain or discomfort. For instance, people that experience this type of disorder also tend to experience anxiety or pain related to their anus or having to go to the bathroom, if they're constipated, if they experience any sort of uncomfortable sensations back there. That tends to co-occur, which lends us to think that any sort of pain or discomfort in the area is thus related to trauma. So here, there's not necessarily a physiological cause for it. They might automatically engage in some kind of tension, but not all the time. Sometimes they just experience pain. You would want to make sure the person gets a full physical exam and make sure there's not something else happening. A lot of times folks will come to treatment for having vaginal pain during sex. And you're like, okay, well, when was your last pelvic exam? And they tell you it's been 10 years. And you're like, oh, okay. So then they go and get a pelvic exam and it turns out they have cysts or some kind of fissure or some kind of other issue, which would then explain. So we would only give this diagnosis if there's no underlying physiological problem. So if we're going to actually look at a sexual behavior, obviously you're going to start with talking to the person. And you have to really, really understand this person's culture, what their expectations are, and where they got their expectations. So when we're looking at issues with sexuality, you're kind of opening a whole can of worms around other issues. There could be sexual trauma, there could be beliefs based on their previous experiences. There could be beliefs just based on their religion or faith community where they are taught that something is normal or abnormal or moral or immoral, but it might be reflective of the larger culture. And so you have to be really careful with therapy with this kind of thing. Because remember, you're not trying to convince people that their beliefs are wrong. You might work on helping people understand if they have certain beliefs that are maladaptive or certain beliefs where they need to work more on self-acceptance, or some of it could just be educational. Maybe they don't know what's considered to be normal and abnormal, or what would be considered to be wrong or, morally abnormal culturally. So you're going to have a whole range of clients who have all sorts of different things going on. And so treatment isn't just going to be about the sexual issue itself. Treatment is going to be around all of those other kinds of issues and helping them really understand like what's happening to my body and why is that happening? And are my expectations for my body realistic? So medical evaluation, of course. If the person just started having this problem because of a medication that they're on, it's probably the medication. Typically that goes away over time. You see people complain about this a lot with antidepressants, anti-anxieties, SSRIs, sometimes SNRIs. Usually the side effects go away after a few weeks or a few months. And so you want to make sure that your client doesn't just stop taking their medication because of these side effects. It could also be helping your client learn to engage in other behaviors. So maybe their depression is so bad that they need to be on medication or else they get suicidal, and the side effects are really intense. And then your work as the therapist becomes working with them on finding other ways to engage in sexuality or other ways of finding intimacy that don't necessarily require penetration. Physical conditions. Somebody has neurological issues. There are certain medical conditions that just lend themselves to having a lower libido. Sometimes it's something just like having depression can lead to lower libido. Being manic can lead to higher libido. We've talked about that a lot before with the other diagnoses. If there's something medical going on or you suspect that there's something medical going on, you could have the person engage in testing with the caveat that that could be really uncomfortable for some people. So let's say it's due to trauma, and then you have the person go and do a study where they are essentially watching pornography and we're going to measure the blood flow, to your genitalia. That could be really triggering for different people. So you don't see this testing done often. You mainly see it done in people who are having a lower libido or lower ability, less frequent ability to become physically aroused or reach orgasm than their baseline. And they're really, really concerned about it. They think there might be some kind of medical issue. So typically they're the ones who seek out that kind of testing. So, of course, there are lots of biological reasons this could happen. And, as a therapist, you're going to be treating the other issues. So if it is because of a biological issue, your job is going to be to help them cope. In our culture, people have really strong identities around sexuality. People have really strong identities around gender and sexuality. So a lot of your work might be helping the person cope. Like, okay, you have this illness, your libido is going to decrease over time. How do I help you deal with that? Or what are other ways that we can help you find intimacy, engage in sexual behavior, all that kind of stuff. If it's psychological, so this tends to be cyclical. People that have expectations that they should be able to engage in sexuality more frequently or more intensely than they do will then develop anxiety about it, or they will develop negative thoughts about it, or they start to think, well, I must be unattractive, or my partner finds me unattractive, all that kind of stuff. And then the anxiety itself, the sympathetic activation. People cannot engage in, I should reword that. People that don't have any other kind of issue, psychologically, when a person is in a sympathetic state, they typically cannot have sex. because it comes down to that whole fight or flight thing. So if a person is in fight, flight, freeze mode, they typically become less sexual because as a caveman, I mean, we've evolved to not engage in sexuality or reproduction when we are fighting off a bear or when we don't have enough food for survival, so on and so forth. People typically engage in higher sexuality when they're in a parasympathetic state. Exceptions would be if they have a history of trauma and they become hypersexual when they're experiencing sympathetic activation, so that fawning type behavior. Another exception would be if the person is having manic episodes and they engage in high risk sexual behavior as a result of their manic episode, things like that. So a lot of the underlying treatment here is going to be around treating anxiety, helping the person return to a parasympathetic state so that the body can then more easily engage in sexual behavior. Let's see here. Talked about this. I love this because that's research that's actually been done. We're like, hey, we're gonna hook you up to something where you might get shocked, and then we're gonna play porn for you and see what happens. Probably some long-term trauma associated with that, but the research has been done, and so it is in there. All right, here's where things get a little more interesting when we talk about arousal. So what we consider to be functional versus what we consider to be dysfunctional, and whether or not the person will then engage in more increased sexual behavior or whether they will avoid sexual behavior. A lot of it comes down to demands or expectations. So this could be things like, again, working with young people where maybe their only experience is what they've heard about in media, so they think that they should be more sexual than they are, or vice versa. When people feel good about their sexuality, they tend to be better able to engage in sexual behavior. When people don't feel good about their sexuality, they tend to have more trouble engaging in sexual behavior. And so it becomes very, very cyclical. And then the therapy work becomes all around helping them feel better about it, or normalizing or addressing those underlying stress issues. Different things to talk about when it comes to sociocultural issues. A lot of times when you work with couples or individuals who are having some sort of sexual dysfunction, it comes down to an issue of communication. Maybe they're not getting aroused because they don't have things that are arousing around them. Maybe they've not discovered what's arousing for them. Maybe their partner is engaging in behaviors that aren't arousing for them, and there are other behaviors that would be arousing for them. All sorts of different stuff there. Obviously, trauma, pretty self-explanatory there. Social and cultural issues. So in certain groups where sexuality has this sort of moral judgment placed on it, people will experience more shame, more guilt feelings, more anxiety, all of that kind of stuff about their sexuality, whether it's being what they consider to be overly sexual or if it's what they consider to be undersexual. Education. So we have talked about this a lot. Most of the time when you have people come into your office with these sorts of issues, just educating them makes a huge difference because they really just don't know what is actually normal compared to what they think is normal. All right, so skipping the rest of that because it's all stuff we've already talked about. Paraphilia, not the same thing as a sexual dysfunction. Okay, I want to make that very, very, very clear. So with paraphilias, it is outside of what we consider to be a normative range or something that's inappropriate. Lots of range here even. And we want to also distinguish between something like a fetish or something like a kink from an actual paraphilia. So a fetish or a kink is when a person is engaging in behavior that is fully consensual and they're choosing to engage in the behavior. Compared to something like a paraphilia where the person can't necessarily help their desires or if it's causing some kind of damage. Here are all of the diagnoses in here. Some of these will likely change in the DSM-6, for instance, transvestic disorder may or may not be there later. So we also want to distinguish between whether the person is just having the psychological aspects or whether they're actually engaging in the behavior. It won't change the diagnosis, but it will change the type of treatment that you give them. And you have to really think about reporting issues. So if you have a client that's coming to you and saying, you know, I'm having these distressing thoughts where I'm only aroused by children, or I'm only aroused by my children or my siblings or something like that, the treatment you do is going to look a lot different than if they come to you and say, hey, I did XYZ. That becomes a reporting issue. And it becomes a different type of treatment, because the goal for one type of treatment is going to be to reduce the thoughts, whereas the goal for the second type of treatment is going to be really to focus on harm reduction and reducing or getting rid of the behavior for safety purposes. So, photoerotic disorder. This is where people have essentially an issue where they are only able to achieve arousal, orgasm, or ejaculation by basically unconsensually having physical contact with another person. It doesn't always have to be rubbing the genitals. It could also be, people probably heard about the Trimet guy a couple years ago that was like cutting people's hair. That was a whole thing. Stuff like that. The issue here is that, again, it's unconsensual, but it's also a feeling of power and control, where either the person is aroused by the fact that the people around them that they're doing this behavior to can't control it, or it can be the person experiencing it feels like they're not in control anymore. So let's talk more about what the actual DSM says about this, as opposed to just your book. Everybody has their DSM, right? Because you're supposed to. So what are some things that you find in your DSM that they didn't talk about in the book? I'm going to go up to page 685. And flip over to 691.
What page did you say?
So 691. The whole section starts on 685, but this particular diagnosis starts on 691. So the main thing here is that in order to actually get this diagnosis, the person has to be engaging in the behavior. It's not just that they're fantasizing about the behavior. It's not just that they're having thoughts about the behavior. It's that they've actually engaged in it. They've actually experienced physical arousal, and they've actually touched or have been rubbing up against a non-consenting person. One thing that the DSM does not differentiate between is the age of the person or the gender of the person. So the issue here for the client experiencing this diagnosis is the lack of consent, and then the feelings of lack of control. So regardless of age, gender, so on and so forth, this is all about the feeling of essentially moving one's body against another person's body, where they don't have control, they're not consenting, they might not know about it, all that sort of stuff. If it's in a controlled environment, so let's say the person is incarcerated, or they're at some sort of institutional setting where they don't have physical contact with people, then you might look at things like just having the thoughts or fantasies or arousal, that kind of thing. And then if it's in full remission, note that full remission specifies it has to be happening for at least 5 years in an uncontrolled environment. So the person's not in jail, they're not in prison, they're not in a hospital, and they haven't engaged in the behavior for at least 5 years. A lot of the things in the paraphilic disorder section have very, very specific concrete measures because we might be using them in forensic type settings. So if I'm testifying in court and I say this person's in full remission, they better be in full remission, right? It can't just have been a year, it needs to reach that 5-year mark. Fetishistic disorders. So this is people that can only engage in sexuality with non-human objects or certain body parts or certain objects associated with sex. Now, it's not just that the person enjoys those things, it's that the person cannot reach full arousal, orgasm, or ejaculation without those things. Because lots of people have things that they like, right? Lots of people might have certain body parts that they like. Lots of people might have certain types of clothing that they find sexually arousing. It doesn't reach the level of a diagnosis unless they cannot achieve or engage in sexuality without that object being there. Oops. So again, you don't want to diagnose somebody if they just have like some sort of kink or something. This is where it actually causes distress. So they're trying to have sex with a partner and they can't engage in sexuality without the object of choice being there. Voyeuristic and exhibitionistic disorders. So again, we're not going to diagnose somebody just because they might enjoy this type of behavior. It's when it becomes problematic. So if the participants are not consenting, so some people enjoy or they get sexual gratification from watching others have sex, or they get sexual gratification from others watching them have sex or masturbate or whatever. This is where you would diagnose these if it comes down to the other person doesn't know or the other person's not consenting. And that's the big, big, big difference with these. And the other thing could be that the person over time or even immediately is unable to reach sexual gratification without engaging in one of these behaviors. So they actually have these in the very beginning of the DSM, and they have specifications. So the specifications are going to be things like, is it all around exposing genitals? Is it around exposing genitalia to children versus adults, or to both? So you would look at the actual context of the behavior. And you would differentiate this from something like, say, pedophilia, which we'll talk about here in a few minutes. It's kind of the major, one of the more commonly diagnosed issues. A lot of the paraphilias aren't diagnosed often because people are really ashamed or they don't want to come to treatment. Or we only see really, really extreme cases where the person is engaging in the behavior and they end up getting arrested and they're in mandatory treatment. So treatment when it comes to paraphilias is kind of a whole mixed bag. Because of that, you might have people that have issues with this behavior, but they're not coming to treatment because they don't want to get in trouble.
How effective is mandated treatment for these kinds of disorders?
Depends. So with juveniles, pretty effective. Juveniles show about a 5% recidivism rate, which is still high, but much, much lower than adults. With adults, treatment, and again, when we look at treatment, for mandated treatment, we're talking about reducing the behavior or getting rid of the behavior. So recidivism meaning the behavior never happens again. They don't get rearrested, they never do it again, or they don't get caught for doing it again. With adults, recidivism is still at about 20%, so fairly high. All right, sexual sadism and sexual masochism disorders. So the person is only able to experience sexual arousal, orgasm, or ejaculation while inflicting pain or humiliation. So two different things. And then vice versa would be experiencing pain or humiliation. A couple of additional specifiers in the DSM about this. So if it is with issues around breathing, the person enjoys either cutting off someone else's breathing or they enjoy having their own breathing cut off. and it's causing some sort of significant distress. So again, you're not going to give somebody this diagnosis if it's just something that they enjoy as part of their normal sexual practice, assuming that it's consensual between adults, so on and so forth. But this is typically going to be the person who doesn't want to enjoy these types of things. They have a lot of shame around it, or they can't achieve physical arousal, orgasm, or ejaculation without the behavior, because that would then cause the person distress. Or if they say, over time, they might feel like they have developed an addiction to the behavior, especially when it comes to asphyxiation, because we know that asphyxiation causes changes in the brain that are very similar to what we see with addiction. So when it starts to cause the person distress and when it starts to become dangerous, or if it's non-consensual, that's really when we would give somebody this diagnosis. Sadistic rape. So your book makes a point that not all rape is around sadism, but some of it is. Lots of problematic content in your book here. I will let you read that on your own time. But according to the DSM, what we're looking at here is a person who cannot achieve any sort of sexual gratification unless they are engaging in some sort of forced sexual behavior and some sort of sadistic forced sexual behavior. The difference would be that the person who meets the diagnostic criteria, again, cannot achieve any sort of sexual arousal, ejaculation, or orgasm without being exposed to this sort of material. Pedophilic disorder. So we want to, again, differentiate pedophilic disorder from pedophilic behavior, because not everyone who sexually abuses children actually meets criteria for pedophilic disorder, which sounds really counterintuitive. But we know that a lot of child sex abuse is about power and control, or sometimes sadism, wanting to inflict pain on another, that kind of stuff. Not a lot of research as to why, but the vast majority of people who do meet criteria are male. Some of this could be because a lot of the research has been done in forensic samples. Not a lot of people who experience pedophilic disorder come to treatment unless they're forced to because they've engaged in the behavior, or it could be that they're ashamed. Maybe they've never engaged in the actual behavior, but they have a lot of shame and guilt around even just having the thoughts or the arousal, and so they don't come to therapy because of that. What we do know is that treatment can be really, really effective for people who have never engaged in the behavior. So for people who experience the attraction, for people who have the arousal, all that kind of stuff, but they've never actually abused a child, we know that treatment is really, really effective in helping them over time reduce the arousal, or learn how to experience arousal with more normative experiences, like with consenting adults.
So would that be using like CBT or something like that to change those cognitions, or would you use something else?
Typically a combination. So most treatment protocols, again, have been done on offenders, and a lot of that is about building empathy. And it depends on the cause, right? So some people just experience pedophilia and there isn't an obvious cause. There's this kind of stereotype that everyone who engages in child sex abuse has been abused themselves. What we have found in the research is that that's not true. Most of it historically has been based on self-report. And then when they actually do research and say, okay, well, we're going to polygraph you, all of a sudden that self-report changes. So treatment without behavior, you're going to do some CBT. You're also going to do some DBT and kind of look at more nuanced emotional experiences. If there is an underlying trauma, you're going to treat the underlying trauma. And some of it's going to be exposure therapy. So you're going to help the person learn to engage in sexual behaviors that are appropriate and safe. So you're going to help the person learn how to become aroused with adults and with consenting adults. You're going to work with learning about what it is about prepubescent children that they find attractive and kind of looking at it from that lens. With the behavior, if they are actually engaging in sex abuse, then you're going to focus primarily on getting rid of the behavior. You're going to do a lot of empathy work. You're going to do a lot of work around learning how to reduce desire or arousal in general, so on and so forth. So the stuff that your book says about this is not necessarily accurate because there are specifiers. If they are only aroused by prepubescent children, that's a specifier. If they are aroused by both prepubescent children and adults, that's a specifier. So we call that exclusive or non-exclusive type, page 697. If it is limited to incest, that's a specifier. If it is limited to gender, that is a specifier. A couple of other things that make pedophilia as a diagnosis interesting is that you don't include normative adolescent behavior. So oftentimes, or not behavior, but thoughts and urges. So oftentimes you will have somebody who, you know, maybe they're in the 8th or 9th grade or 7th grade, they've reached puberty, but their peers have not, and they might still be attracted to prepubescent peers. What you want to see is, does that go away over time? Have they now gone into adolescence and adulthood and they're still attracted to prepubescent children? Or does it go away and there's just a mismatch between their physical development and their peers' physical development? So lots of nuance there. A lot of it also has to do with power difference. So criterion C in the DSM talks about there being an age gap. So we're looking at folks who are at least adolescents and where there's some kind of gap between them and the object, in this case, the prepubescent child, where they're not just same age peers who are at different phases in development. There's some kind of gap that lends itself to power difference, so on and so forth. Incest could be sibling, it could be grandchildren, it could be any relative. With incest, we typically refer to first-degree relatives, but also use your clinical judgment. So in some states, incest does not count cousins. Oregon is one of them. Uncles and aunts are not considered incest in Oregon. In other states, they are. So when you're diagnosing this, decide if you want to diagnose based on the legality or the clinical piece. So if I have somebody that's coming to me and saying, I'm only attracted to my little cousin, let's say they're 5, okay, and the other person's an adult. They meet the criteria for pedophilia. Whether or not I choose to add an incest specifier is really going to be up to the sort of cultural norm for that family, and the norms for where we are, and it's going to depend on the legality piece. So you kind of have to use your judgment there and decide. Folks that have issues with paraphilias in general tend to have relationship issues. For obvious reasons. So if they are unable to engage in sexual behavior without specific objects, or they are unable to engage in sexual behavior with adults, all that kind of stuff, they're going to have trouble with relationships. And you can look at different comorbidities. So you might see personality disorders here, specifically things like antisocial personality disorder. Many of these, so for instance, an offender, a person who's actually offended against children, but doesn't have the, let's say they offend against children, but they don't meet full criteria for pedophilic disorder. I'm probably going to look at something like antisocial personality disorder because it appears to be due to primarily the power issue and the enjoyment of harming the other person. You might see other associated things like other recurrent law-breaking behavior, complete lack of empathy, all that kind of stuff. There are people that will complain about OCD-like things where the thoughts and urges are ego dystonic, and they might not necessarily only have sexual thoughts or arousal based around the fetish object, or in the case of pedophilia, prepubescent children, so on and so forth. So you're going to do a lot of kind of examining around what the underlying thought pattern is, when it's happening, that sort of stuff. Are they having intrusive thoughts? Let's say they're engaging in sexual behavior with a consenting adult, and all of a sudden they start having intrusive thoughts of something like a fetish object or a prepubescent child, all those sorts of things. So this model is extremely outdated because we now know that there are lots of folks with paraphilias, specifically pedophilic disorder, that don't actually have early inappropriate experiences. Again, most of the research about this until recently was all based on self-report. There was a study, the first of its kind in 2007, where they did the whole thing where they worked with offenders and asked one group of offenders about early sexual abuse experiences or early sex experiences, and found that they all reported really, really high rates. Then they took a second group of offenders and said, okay, we're going to ask you these exact same questions, but we're going to do them with a polygraph. Even though we know that polygraphs aren't a great measure of honesty, it was the threat of polygraph that lended to very, very different answers in offenders. So that tells us two things. First of all, that actual behavior based on paraphilic disorders doesn't necessarily have a link to early inappropriate sexual experiences. Number two, it tells us that the behavior does have a link to things like antisocial type personality traits or personality disorder. What we don't know a lot about is folks that are non-behavioral. So folks that have the thoughts, desires, so on and so forth, but never actually engage in the behavior, never get caught with the behavior, because we just don't have a good research sample. Oh, let's see. It is 11:55, so we'll get through this quickly. Your book has a lot about different types of treatment. So we talked about this a little bit already. You would help the person work with learning how to experience arousal with more socially acceptable and safer types of sexual behavior. I'm going to treat down here. Medications aren't used very frequently because let's say the person has ongoing behavior. I had a client at the prison who was probably the first, well, I guess it's not really a HIPAA issue because incarceration is public data, but I had a client at the prison who was one of the first people who's gotten a life sentence for something other than murder in the state of Oregon. And it's because they were engaging in repeated sex abuse behavior over time with several dozen victims. And the judge was able to use some sort of loophole that basically said, you're going to jail. He got over 100 years. Because our sentencing grid doesn't actually allow for a life sentence. But this was a case where the person continued to engage in the behavior despite treatment and so on and so forth, which then as a mental health professional, we're like, well, this isn't, if they're not responding to treatment, then I diagnosed that person with a personality disorder. But there are cases where the person might get some kind of medication where it completely eliminates the ability to become physiologically aroused. Not very many states do that because the general idea is, well, they're incarcerated, so they can't hurt children anymore. So why should we bother giving them this medication? However, if the person engages in the behavior that often or to an intensity such that they do end up incarcerated for a long period of time, there's a good chance that they enjoy, if it's related to a personality disorder, there's a good chance that they are engaging in other types of abusive behaviors. So for this individual, he continued to engage in sexually abusive behaviors with adult peers, specifically those with severe mental illness and those that were intellectually disabled, which told me as the provider that this isn't just about pedophilia. This isn't just about children. This is about power and control and harming others. Oregon does not use medication. A lot of states do. It is a contentious topic. So you can read all about that. We know that it's effective, but it does kind of become a civil rights issue. So lots of stuff there. All right, gender dysphoria, nothing to do with paraphilia, nothing to do with sexual dysfunction. So I know we talked about this before earlier on. So gender dysphoria, not every person who's transgender experiences dysphoria. Transgenderism has existed throughout all of history. It's documented very, very, very early on in the, sort of first written documentation. In addition to that, it's documented in oral history. It's documented across cultures. It looks different across different cultures. In some cultures, there are third genders. In some cultures, there are people that have no gender. In some cultures, there are people that have multiple genders. Dysphoria is specifically when a person, their body does not feel correct. So there are transgender people who are perfectly comfortable with the genitalia that they have or the secondary sex characteristics that they have, but they identify psychologically as a different gender or as non-binary. Gender dysphoria is specifically if the person is experiencing really marked distress as a result of their body parts, where their body part might feel, this could be things like hair, it could be things like genitalia, it could be things like secondary sex characteristics. It could be about the way it looks, it could be about the way that it feels. And you want to differentiate between this and general body dysphoria, right? We talked about that when we talked about the somatic symptom disorders, that this is not the same thing. So it's pretty rare. Again, more common among males than in females. What does that mean? So most of the stuff in the DSM talks about cisgender when they are referring to men or women or males or females. With gender dysphoria, what we see is that for individuals that are transgender, who, if they are designated male at birth, which is not the same thing as being cis male, if they have external male genitalia and they identify as transgender, there tends to be a higher rate of dysphoria, a lot of which is related to cultural expectations about what gender looks like. So they might have more issues around the external genitalia. There might be more issues around having body hair, all of those things. A lot of that comes down to the distress caused by not being able to pass as their correct gender, or feelings of unsafety due to their body, or just general discomfort with the body parts. When we talk about people being biologically male or female, that's another thing we need to be really careful with because we don't actually know what that means. Most people are considered biologically male or female based on their external genitalia only. However, we know that biology means a lot of different things. It means chromosomes, it means hormones during fetal development, it means hormones during puberty, it means internal genitalia, sex organs, it means external genitalia, and it means secondary sex characteristics. We know now, or I should say we've always known up until the last 100 years where we decided to unknow, that out of all of those categories, there could be people for whom things don't align. So their chromosomes might not match their internal or external sex orgasms, their organisms rather. There could be people for whom their secondary sex characteristics don't match their genitalia. There could be people for whom their secondary sex characteristics don't match their chromosomes, all sorts of different combinations. We also have folks that are intersex, which is a whole other thing. So again, normative variations. So you would really only diagnose gender dysphoria if outside of all those normal variations, the person has an extreme marked discomfort with parts of the body. What this can look like, the person might end up, there are some biological causes. So again, this is outdated. What we know now is that if we do brain scans, people with gender dysphoria, their brains tend to show patterns similar to cisgender individuals of that person's gender. So let's say you have a transgender female person who might be born with, designated male at birth, and then they realize they're transgender. If they have dysphoria, brain scans tend to show brain patterns that are more similar to those that are designated female at birth, meaning their brain perceives their genitalia incorrectly, or they perceive different body parts incorrectly in ways that match cisgender individuals that do have those body parts. So we know that there is a biological component. For treatment, the only two treatments really are to make the body match what's going on in the brain. Intersexuality is a big problem because it's really common. About 1 in 1,000 births have ambiguous external genitalia. And up until very recently, most of the time, those people would receive surgery at birth. And then they grow up and they're like, wow, this doesn't feel right. What's wrong? And then they develop gender dysphoria. So that's a thing. We also know that the majority of people that get, it doesn't just have to be surgery, but also hormonal treatment or hormone replacement therapy so that their body starts to feel the way that lines up with what the brain scans are showing. To do these, and some of you will, if you do additional training, you can get certified as doing, usually people have to go through therapy first to qualify for these types of treatments. And they have to go through a whole assessment process and all that kind of thing. So there are certification programs out there if that's something folks are interested in. I do them as a contractor with OIA and a few other things, where the person has to go through treatment for a while to make sure first that it's not some kind of other dysphoria, that it's not due to just normal identity issues like during adolescence, that it's not due to an underlying physiological issues, like maybe they are intersex or maybe their chromosomes don't line up, that kind of thing. You know, you want to look at all those other sorts of things and see what's really happening here. We are out of time. I will let folks read about the rest of these in the DSM. And yeah, your book also talks about gender nonconformity, which again is really problematic, grouping in the same chapter as paraphilias. Lots of kids play with gender, lots of adolescents play with gender. Not really a thing. Yeah. But we are out of time, so I will leave that to all of you to read about and draw your own conclusions about. If you have questions, feel free to email me or go on the school library and look up the research, because there are lots of things that the research says that the book does not say, and vice versa. And I will leave you with that. Next week, we are supposed to meet in person. I've already gotten a few emails from folks who don't want to. I know I said this at the beginning of class, but please feel free. If you don't want to for any reason, just don't. I don't have a strong preference. I will have Zoom on during in class and it will be recorded as usual. Just email me and let me know ahead of time so I can make sure to keep an eye out for attendance and whatnot. Any other questions? Sorry, I can't stay late today because I have clients starting at 1. And so I will see you all next week. Have a lovely week. Enjoy the spring. Watch out for daffodils.
So we should just log on this link if we're going to do it via Zoom.
Yes.
Okay.
All right.
And then where is do we have a link for the midterm?
It is on Canvas and it will become available that Monday morning of that week.
Oh, it's not this week. It's next week.
Yeah, in fact, let me show you and make sure that I didn't mess it up because I'm continually messing things up on Canvas. Let's take a look.
That's great. Oh yeah. Okay.
Sure.
It's in this. Yeah, I was the week ahead. Okay, phew.
No, you're good. And like I said, I think I mentioned this last week, but it's going to be open for the whole week. That way you can choose when you take it. And I did not put a time limit on it because it's open book and blah, blah, blah. Let me see here. Blah, 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 blah. Midterm exam will become available on the 28th at 6 a.m.
Awesome. Okay. Thank you.
All right. See you later, guys. Bye.